Hi, everyone, and thank you for joining today's MIPS Value Pathways, or MVPs, Town Hall. During today's webinar, the Centers for Medicare and Medicaid Services will share policy considerations for the MIPS Value Pathways, and stakeholders will be invited to share feedback on the design and implementation of MVPs, including subgroups, MVP design, and MVP reporting and scoring. So now I will turn it over to Katie Moore, Health Insurance Specialist at CMS, to begin.
Great, thank you, Lauren. And good morning, everybody. I know it's an early start today, so we really appreciate folks that have already jumped on today's town hall. Especially want to just give a quick thank you to any of our frontline clinicians that we have on today and their staff. We know this is an incredibly busy time right now trying to address COVID-19 in your practices and communities, and we really appreciate you taking the time to join us and give us your feedback today. Throughout the day, we are going to have a wide variety of our stakeholders and different partners joining our different sessions, and we're really looking forward to hearing from all of you and getting all of the different perspectives that'll make our program even better. So we definitely have a packed full day today. And unlike our normal, typical educational webinars that we do, where we're CMS staff, we spend a lot of time giving you all information or talking about our finalized policies and different things. Today's format of our town hall is going to be a little different than that. And we really want to focus today on you all and listening to you and getting your feedback on the different concepts that we're going to talk through today, that we're going to share with you, so that we can take your input into consideration as we continue shaping the future of our MVP policies. We can go ahead and start with our first slide. Great, thanks. And this is just a very quick run through of our agenda for the day today. So first, we're going to start with a brief welcome. We'll get to you in a few minutes, and then just a really quick slide on some background. Then we will start our first session on subgroup reporting. And we'll take a break for lunch, because I know it's very hard to sit here for a full day. And then we will finish up with our last two sessions on MVP overview, and we'll talk through some reporting requirements and scoring concepts that we will be talking through later this afternoon. And just wanted to make sure, I know people always ask us at the beginning if information will be recorded. So yes, we are absolutely recording today's presentation. And I know it's a long day, so don't feel like if you can only come in and come out, that is absolutely fine for today, and come in when you need to give your feedback. We will have a full recording of today's event available, as well as a transcript, as usual, and these slides probably in the next couple weeks on our QVP webinar library, where all of our other information is housed as well. And before we get started, I just want to give a quick reminder that we will be accepting formal written feedback. We're going to take all of your verbal comments in today as well, and we have a lot of our partners signed up to speak today, so that was great. Thank you for that. But we will be accepting formal written feedback for another week after the event, so through the 14th. And more information on that is provided in detail on our QPP resource library. We have our MVP Town Hall Prep Guide you can refer to for all of the details on what we're getting feedback on today, and then how to submit that to CMS for consideration. All right, so I'm not going to hold us up any longer. It's my pleasure this morning to introduce you to Dr. Michelle Schreiber. She is our Deputy Director for Quality and Value at the Centers for Clinical Standards and Quality. And Michelle, I think you have a couple more titles in there I left off.
Yeah, that's okay. Thank you so much, and good morning to everybody. Sound check, can I be heard, Katie?
Yes. Yep, you're great.
Okay.
Thanks, Michelle.
Very good. So to all of you, good morning and Happy New Year. This is going to be an exciting new year as CMS puts more development towards the MIPS value pathways, and we're excited about this in MIPS. We welcome all of you today to this conversation, and it is meant to be a conversation. When Katie said we're looking forward to your feedback, she was correct. This really is meant to be us doing some presentation, but mainly listening to you, the stakeholders, for your feedback so that we can shape this program in a way that is very collaborative and meets people's needs as best as we can. Let me start by thanking a number of people. First, our experts on the MIPS team at CMS and others on the CMS team, as well as our contractor Ketchum for organizing today. But in particular, thanks to all of you. We recognize that this past year has been exceptionally difficult with COVID and other stresses, and that healthcare has really been stressed in a way it never has before. Your dedication is unbelievable, and really healthcare and healthcare frontline providers are the heroes. So thank you for everything that you do. We have obviously had a number of questions on what to do with MIPS in 2020 and what to do with the data. I just want to remind everybody that we have extended the deadline for filing for an emergency circumstances to the end of January, and Katie can provide that date. But let's talk about MIPS value pathways and what are they, and frankly, why are they? First of all, ensuring that patients are getting the care that they need, especially in this COVID pandemic, is the most important priority that we have. We have listened to your feedback about the MIPS program over the last several years, and we recognize some of the concerns that MIPS is too complicated, that there are too many choices, that the activities of the 4 categories, quality, improvement activities, cost, and promoting interoperability, aren't always connected. MIPS is less meaningful to some specialists who think that there are largely primary care measures, and how does this relate to my specialty? And so we really thought about that and thought of how we can improve MIPS in smaller, more cohesive ways that will limit burden, that will make it more meaningful, not only to providers, but ultimately make it more meaningful for patients as well. So MIPS value pathways is a concept of doing exactly that, that we will have a set of measures meant to really drive towards improvement of a single clinical problem. And by that, let me just say that as you develop and we develop these MIPS value pathways, the first thing to start with is really what it is that we're trying to accomplish. Is it, for example, improving prevention care? That would be one, and is one that's under development for a MIPS value pathway. And then what would it look like to improve prevention care for all across the board? Improving prevention would be improving smoking cessation, for example, or maybe it's depression screening, or maybe it's reducing obesity, or maybe it's better cancer screening. But you can imagine in your own mind the big areas that would need to be included if what we wanted to accomplish was to really drive improvement in prevention. And by the way, for those of you who don't know me, I'm a primary care physician from the city of Detroit. And so many of my examples are going to be around primary care, but this is also meant to be very relevant for specialists. So that's the concept really behind the MIPS value pathway, is that they're meant to be coherent, they're meant to address a significant clinical issue. We're also not looking for a huge proliferation in the number of MIPS value pathways, as we have seen sometimes in measure proliferation. We have no set number in mind, what's the right number of MVPs, but we'd really like to limit it as much as possible. But we also want to ensure that providers do have an adequate choice so that there is something that they find that would relate to their specialty. As I said, start by naming the MVP with the intent of demonstrating what the end goal is, and then think it through from there. But there are some key underlying philosophical principles that we're also trying to accomplish, as well as improving a specific clinical topic. One is that we very much want to increase patient reporting. So we're asking, as the MVPs are developed, that first of all, patients are included in developing them, and their perspective is included. Many of the specialty societies that we've been collaborating with so far are bringing patients onto their team to ensure that they hear the patient voice. But be thinking of it's their patient-reported outcome that you can be including and that we can be including in a MIPS value pathway. The second is the preference for digital measures. CMS has made the commitment that all quality measures will be digital by 2025. Now, we know that that's really an aspirational goal, but we are driving towards that. And more, we're looking for only measures that are digital. Some of that could be electronic clinical quality measures that come from electronic medical records. Some of that could be other digital means. So we have a broad definition of digital, but we're very intent on driving forward for digital measurement so that we can reduce the burden of data collection, and also so that we can leverage advanced analytics to be looking at the data and maybe even thinking of quality measures in a different way. We want to be sure that we're introducing concepts of promoting equity. So should we be thinking of having social risk factors or reporting that can be stratified so that organizations can at least look at their data based on stratification for SES, because we think closing the gaps in equity is extremely important. We want measures that are aligned across settings, and potentially even ultimately aligned across MVPs. As we start developing in collaboration with others, the MIPS value pathways, ideally we can cross disciplines, and some of these may be developed with multiple subspecialties or specialties working together, such as the prevention one that I alluded to. We've been working in partnership with several specialty societies because many types of providers would support improved prevention. We'd also like to introduce the concept for your consideration and feedback ultimately of whether or not we can link MIPS value pathways to granting CME or maintenance of certification, because ideally, wouldn't it be nice as providers are working for improving quality that they can get benefits in other parts of their practice? This all aligns very well with the CMS vision of the future of quality measurement and the CMS Quality Action Plan. Most of you are familiar with the fact that we started meaningful use several years ago so that we could narrow the focus to specific measures and topics of measures. We continue to evolve meaningful use to meaningful measures 2.0 and have been using external stakeholder conversations to get feedback on the CMS action plan and meaningful measures 2.0. It really encompasses many of those broad concepts that I just spoke about: the alignment of measures, the transformation of measures to digital, the increasing patient-reported outcomes measures or the patient voice, and finally, disparities. So with that, we're very excited about MIPS value pathways. We look forward to all of your collaboration. Your feedback is particularly important to us, and we hope to make this successful. Just one further note, our intent actually had been to introduce into rule writing MIPS value pathways this year. Because of the COVID pandemic, obviously people and their resources have been diverted elsewhere. Our goal is to introduce several MIPS value pathways into rule writing in the coming year, and over the next several years to continue to introduce MIPS value pathways, so that, as you can see, MVPs will be introduced via rule writing so that we can also have public comment on them. And we think that that's very important so that we can have MIPS value pathways that are most meaningful to the widest number of stakeholders. Once again, we look forward to your collaboration, and thank you for attending today's session. Katie, let me turn it back to you.
Great. Thanks so much, Michelle. All right, we can go to the first slide, or next slide. Thanks. Okay, so we're not going to spend too much time on background for MVPs. We recently had a deep dive MVP webinar where we went into greater detail about our finalized 2021 MVP policies. We touch on them here on this slide just briefly. recognizing stakeholder comments. And as Michelle said, we're, really want to help focus on clinicians. We want clinicians to be able to focus on their patients right now. So we are not introducing, or we did not introduce MVPs into the program for the current 2021 performance period. The earliest that we will have MVP implementation will be next year with the 2022 performance period. But in 2021, we did finalize some MVP guiding principles to include patient voice, subgroup reporting, a fifth principle related to our goal of promoting digital performance measures data submission. And then we finalized a set of criteria that gives people a lot of the details you were looking for. And hey, I want to submit this MVP. Here's our idea. Is this what you're looking for? So this criteria really sets out what we're envisioning for these MVPs. And I'm excited to say that we have updated our MVP webpage on qpp.cms.gov. We have a specific MVP webpage that has all of the information you need about MVPs with links to our different resources that we have available. And we now have a specific page dedicated to MVP candidate submission. So it provides links and information to our MVP submission template that is also available. And so I encourage everybody to check out those resources, as well as our webinar library, where we have currently posted our slides, transcript, and recording of our deep dive MVP webinar we had a couple weeks ago. So I encourage everybody to check out all of that information so that we can really focus today on hearing from you all and talking about these future policy concepts that we haven't proposed through rulemaking just yet. And with that, I'm going to turn it over to Molly McHarris, who's going to get us started with session 1.
Okay, great. Thanks, Katie. And again, thank you, Michelle, for your remarks this morning. As Michelle noted, we are very much looking forward to everyone's feedback here today. We have a lot to cover throughout the day. And as Katie and Michelle noted, and you'll hear myself and others say this, we really, really do want to hear your feedback today as we work to move forward on our MIPS value pathways. So with all of that, let me dig into our first session. So let me give a little bit of background first as we start thinking about our subgroups. So over the course of the MIPS program, all of you may recall that we have asked stakeholders at various points in time for feedback on how groups, including multi-specialty groups, should participate in MIPS. Multi-specialty groups, especially those groups with many clinicians, often provide an array of services that may not be captured in a single set of measures. For example, consider a large multi-specialty group that is eligible for MIPS and consists of primary care physicians, cardiologists, and surgeons. Under traditional MIPS, in this example, the practice may choose to report on measures that primarily cover primary care physicians, and typically they do not select measures that are specific to cardiologists or surgeons, meaning that the array of services provided by the cardiologists and surgeons would not be captured. That is typically what we have been seeing for the vast majority of groups that have reported data to us. When we do see that they are multi-specialty in nature, they have selected to choose to report on a set of preventative healthcare metrics. And while we believe that group reporting is, of course, very important, we do recognize that that level of reporting doesn't reflect that full array of services. So under the concept of subgroup reporting, an option that we are considering is that the practice's surgeons may participate in MIPS through forming a subgroup and report through a surgery-specific MVP. We believe that this may better reflect the array of services that surgeons provide and may provide additional information for clinicians and beneficiaries in making healthcare decisions. Under this example, the primary care physicians and cardiologists could decide to report through traditional MIPS at the group level, which also includes the surgeons. One of the consistent themes we've heard from stakeholders, particularly specialists, is that we should allow a portion of the clinicians in a group to report as a separate subgroup. And as Katie has just gone over our guiding principles, I'll just reflect that in our second guiding principle, we did update that to say that MVP should include measures and activities that would result in providing comparative performance data that is valuable to patients and caregivers in evaluating clinician performance and making choices about their care. Specifically, MVPs will enhance this comparative performance data as they allow subgroup reporting that comprehensively reflects the services provided by multi-specialty groups. So just wanted to share a bit of that background as we jump into our first session. And again, I believe that all of you have our content guide as well. So let's go ahead and move on to the next slide. Okay. So as we think about our considerations for subgroup reporting, currently we are considering that the option for subgroup reporting would only be available to groups where clinicians report through an MVP. We recognize that there may be only a limited number of MVPs available to be reported during the initial years of MVP implementation, which may result in scenarios where clinicians may be interested in reporting through a subgroup, but the MVPs available are out of scope for their practice. In this scenario, we anticipate that these clinicians would report via traditional MIPS. Again, we do understand that it will take some time to have a full, robust set of MVPs available for all clinicians to choose from. I also want to note that it is not our intent to promote competition within groups, but recognize that this may be a byproduct of subgroup reporting. We anticipate that subgroup reporting will promote visibility into specialty groups within large organizations, and we want to work with stakeholders to ensure that team-based care is continued. In addition, we believe that as we initially roll out subgroup reporting, it will be voluntary. And also, as part of the initial rollout, we believe that there are some combinations of how we could be receiving data from either the group or subgroup. And I'll be talking through this in more detail in coming slides on some of the options that we want your guys' feedback on. Also, I will flag up front if there are other options we should be considering. We would love to hear those as well. So some of the considerations that we have as we think about group reporting and subgroup reporting is we understand that some of those items would need to happen at the overarching group level, and other items we anticipate could be scored or assessed at the subgroup level. So for consideration, we anticipate that we would continue to have group level evaluation for eligibility, so determining whether or not the entire group is eligible, as well as special statuses. Within the MVP, and we'll talk about this, I believe, closer to session 3, we'll be talking more about the foundational layer and what those reporting criteria, a little bit more detail of what we're thinking about there. We also anticipate that our performance category reweighting and those statuses and flexibilities that would remain at the group level, as well as our hardship exceptions. But we do anticipate that for our subgroup evaluation data, we could have information related, of course, to the subgroup, as well as performance information. So let's go ahead and move on to the next slide, where I will start talking through some of our options to lay out our subgroup identification and election process. Okay, great. So for our first option, it allows for the election of subgroups at the time of performance status submission. So what this looks like is that this allows the subgroup more time to provide to us, CMS, the list of clinicians that would be part of that group. So it includes identification of subgroup participants during the submission period after the performance period ends, and it would allow clinicians that additional time to submit the identification information in comparison to our second option, which I'll go over in just a minute. So from our perspective, we see that there are some advantages and some disadvantages to this option. So some of the advantages we see is that we do believe that this could provide additional flexibility for clinicians that are participating in MVPs and the subgroup option, where this would give them the maximum amount of time to let us know these are the clinicians that we believe should be part of our subgroup. It also allows the comprehensive end-of-year subgroup participant list using a retrospective look, where subgroups can have greater accountability for clinicians that join or leave their practice. We know that this happens from our many years of experience under the MIPS program, and also just reality. We understand that clinicians do not always stay in their same position year after year. So we do understand that there can be changes to the overall composition of a group or a subgroup. And so we do feel that that is one of the strong advantages to this option. Some of the disadvantages, though, is we do worry and we do have concerns that there may not be a full amount of time for us, CMS, to fully reconcile all of the information, including our claims information, our CAHPS beneficiary information, to be able to release our feedback at our typical time frame, which, as folks know who've participated in the MIPS program for many years, we typically try to provide preliminary feedback at the close of scoring and then our official performance feedback in July. So with this approach, we do anticipate that there is the potential that some of those dates may get pushed back. And so we'd like to understand how big of an impact that would be on clinicians. Also under this option, the subgroup clinicians would be assessed on the overall group's administrative claims, quality, and cost measures as a subgroup. Okay, let's move on to the next slide to talk through option 2. So the second option, this is where the election of the subgroups, this happens during the performance period, and so we would need to receive that list at that time. And so I'll talk through the advantages, disadvantages here as well. So what we anticipate under this approach is that prior to the end of the performance period, we would expect to receive a subgroup registration and a participant list around the time that we typically turn off our web interface and CAHPS for MIPS registration, which is the end of June, early July. This option would allow clinicians to be assessed on more information related to their subgroups, but it would require the submission of the subgroup participant list earlier than option 1. So again, instead of after the close of the performance period during the submission window, this would be about 6 months earlier. So some of the advantages here is that this would allow subgroups to be scored on administrative claims, quality, cost measures specific to their MVP. We believe we would be able to do that under this option because we would have more time to actually build within our system. These are the clinicians, their unique TIN MPI combinations that should be assessed on the administrative claims and cost measures at the subgroup level. It also provides increased subgroup performance data to inform quality improvement and patient choice. And we also believe that this would encourage proactive performance accountability by allowing clinicians to know which measures they will be assessed on. Some of the disadvantages of this option, though, is that the subgroup participant list would not be able to be modified after the July 1st date. So new clinicians would not be able to be added for the second half of the year. And so for any clinicians that do join the organization that has decided to participate as a subgroup, they would have to report to MIPS as either as an individual or as part of the overarching group. Okay, so those are our 2 overarching options. So now let's move on to the next slide where I'm going to talk through some additional options that we have on how subgroup scoring could function. So I don't want to confuse folks. The first 2 options, those we're talking about the timing of when we would need to receive from those organizations that want to participate as subgroups. This is who I am as a subgroup, and these are all the clinicians that are part of that subgroup. So now for this next set of options on this slide here, we're going to be talking about how subgroup scoring could occur. So for our option A, the option here is that subgroups would receive a MIPS MVP final score that is separate from the group's final score. So again, the subgroup has a final score that is separate from the group's final score. We believe that this is a relatively straightforward scoring approach, which we feel is a great advantage to our program, which we know has a lot of complexity within it. Some of the disadvantages, though, to this is that it could lead to internal competition within groups, and it may not align with goals around team-based care. And it could also require duplicative reporting. Then the second approach that we have thought of for how subgroup scoring could occur is subgroup scores are rolled up into the group's final score to result in one overall final score for the group. The subgroup scores may or may not be weighted as part of the group's final score. So that's another element that we would love to hear your feedback on if folks are in favor of option B, whether or not there should be any weighting. Some of the advantages of this approach is that the group score incorporates the subgroup performance, and we feel that this could better align with the approach to team-based care. Some of our concerns with this approach, though, is that we do believe that it would add some additional complexity, which again is something that we are always thinking about within the MIPS program and trying to minimize that. And we believe that it also could impact more of a focus on performance data at the subgroup level could be lessened. Okay, let's move on to the next slide with just one more diagram or one more slide I want to go over, and then I will start going over the questions, and then we will start opening the lines up for folks who had first requested to provide feedback, and then for anyone else. So again, hopefully folks are thinking through these as I've been talking through them. So on this slide, just the last piece I wanted to go over. So this is a diagram that we've put together on what we anticipate subgroup reporting could look like in future years when MVPs are widely available and applicable. So what we anticipate is that at some point in the future, there would be subgroup reporting, and the scoring would look like where quality improvement activities and cost, as well as the foundational layer, would be reported and scored at the subgroup level. For multi-specialty groups, reporting at the group level would not exist. So our vision of the future state is that for these large multi-specialty groups, where we recognize that they may have many specialties, at the future, there would no longer be overarching group reporting. Instead, there would be the allowance for a subgroup reporting for the different specialties. So again, this is an area that we would love to receive feedback on our vision, and whether you all agree with this or if there's any considerations that we should have as we look to move this forward. Okay, so that's the background I wanted to go over. So next I'm going to go ahead and talk through all of the questions that we have. I'm going to talk through all of them at once, and then again, we'll pause for those folks who registered and indicated they wanted to provide feedback for our sessions ahead of time. Assuming there is time at the end, which I do believe we will have time, we'll further open up the lines for any additional feedback that folks want to provide on this particular topic. Okay, so thank you for moving on to this next slide. So our first set of questions relates to the identification and election process. So again, think back to those slides I went over with our options 1 and 2. So given the desire to identify NPIs or clinicians at a single point in time, which option is more important to you? Is it our first option, which is where we would receive the subgroup information and the list of participants in the submission window, which again is at the close of the performance period, which allows additional time to submit the identification information for subgroups, even though subgroups would be assessed on less information? Or our second option, which is where we would receive the subgroup identifier and list by July 1st of the performance period, which is about 6 months earlier than our first option. But we believe under this approach, we would be able to assess more information at the subgroup level. Again, specifically when we think about some of our cost measures and our administrative claims measures. So what are the practical implications to consider if clinicians were to join or leave a subgroup after the subgroup identification period? So that applies to both of these options, but probably more relevant to our option 2, if that is the approach that folks are in favor of. And then also, again, these are the options we have come up with, but we would love to hear if there are alternate options that we should consider for appropriately capturing clinicians within subgroups at a single point in time. I also will comment here that as we prepped these options, our team did take a look at the various other cutoff points that we currently use under the quality payment program for our different reconciliations. And based off of our understanding of how those options work and lessons learned, both positives and negatives, that's why we did formulate these options. But again, we would be happy to entertain any other approaches that folks would like us to consider. Let's move on to the next slide, please. Additional questions related to the subgroup identification and election process include that we envision that subgroups are assigned an identification number and believe that it would be beneficial to sustain the subgroup ID number. Are there circumstances where this number should not be sustained from year to year for reporting? And if so, what factors should we consider in determining that a subgroup can no longer use the same identifier? So again, similar to some of the other processes that we've created under the quality payment program, for example, for our virtual groups, and for many of our ACO or APM participants, we typically assign a number. And in this circumstance, we believe it would be beneficial to have that identifier carry over from year to year. But we are interested if there are any other factors that we should be thinking about with that. And as MVPs are created to be more meaningful to the care eligible clinicians provide and to generate more meaningful information for patients, a question we always ask ourselves as we think about how can we encourage or incentivize clinicians to move towards where we ideally want them to. So how should we incentivize the continuation of team-based care within practices? Okay, let's move on to the next slide, please. And so for this slide, we're talking less about the election process and more about subgroup reporting overall. And so the questions on this slide, there is a focus on the impact to our third-party intermediary partners. So again, if we do in our future state have subgroup reporting, what are some of the modifications third-party intermediaries and practices would have to make in order to allow reporting of MVPs for quality measures and improvement activities for a subset of the MPIs within a TIN? Our specific questions are, do third-party intermediaries and practices believe they can manage supporting subgroup reporting over the short and or long term? What should we be considering there? What types of modifications do we, CMS, need to make to our technical specifications to accept the data? Again, we fully anticipate that we would need to create the subgroup identifiers, but if there are other things that folks are thinking of, we'd love to hear that. Also, for those modifications, is there an opinion that those modifications would be so onerous to overcome the third-party intermediaries do not believe that they could support subgroup reporting? And then lastly, as we think about our third-party intermediaries, we'd be interested in folks' reactions to whether or not we should add subgroup reporting to the certified EHR technology requirements that our colleagues over at the Office of the National Coordinator oversee. And then what are the circumstances, if any, where subgroup level data would be available now to allow for subgroups to be assessed on the promoting interoperability performance category? So folks, you may recall when I was going over the slides, we stated that for promoting interoperability, we envisioned that that would still remain at the group level. And that is because we do not believe that there is currently the functionality within the certified EHR technology platform to allow for subgroup reporting. So our question here is, does anyone have information that would make us want to change this fact? And then if this information is available, should we work on accepting that data? And then let's move on to the next slide for the last set of questions under this topic. And so again, thinking about what type of scores we would provide to clinicians who participate as a subgroup. So should subgroups receive their own final score or have their subgroup score rolled into the group's final score? So again, think back to where I talked about the options A and B. Are there alternate options that we should consider for appropriately scoring subgroups? At a future state, should we ever make subgroup reporting mandatory, or should this always be a voluntary approach? And we do want to be upfront and transparent that we do recognize that the movement to subgroup reporting can increase burden on certain practices and certain third-party intermediaries and our partners as we work to implement this. So we do want to be transparent that we do not believe that the movement to subgroup reporting will be without burden. However, based off of the feedback we have heard from stakeholders over many years, and based off of our own analysis, we do believe that the potential benefit of subgroup reporting and the ability for clinicians to really be assessed on measures that are applicable and meaningful to their scope of practice outweighs those burdens. But we do really want to understand that more and make sure that the approach that we lay out has the burden being reasonable and not overly burdensome. And I believe with that, our next slide takes us to our participant feedback. So I will pause here and turn it back to Katie and our Ketchum team to move forward with opening up the lines for our first stakeholder who would like to give us feedback.
Great, thank you, Molly. Okay, so as Molly said, we are beginning the scheduled feedback portion of this webinar. Again, as previously stated, we may have time for open feedback toward the end of the session. But first up, we have Jennifer McLaughlin from the American Medical Association. So Jennifer, we are unmuting your line. All right, Jennifer, apologies. It looks like we need you to connect to audio, so we'll give you a few seconds to log back on. Okay, and in the meantime, we will move on to Ralph Cole from the American Association of Nurse Anesthetists. So Ralph, we are unmuting your line. And Ralph Cole, you may go ahead.
All right, thank you. And thank you for the opportunity to provide feedback during this town hall meeting and for conducting it. It's a very important topic. Obviously, I'm Ralph Cole, the Senior Director of Federal Government Affairs for the American Association of Nurse Anesthetists. The ANA is the professional association for certified registered nurse anesthetists and student registered nurse anesthetists. And ANA membership includes over 57,000 CRNAs and SRNAs, representing over 90% of the nurse anesthetists in the United States. CRNAs are advanced practice registered nurses who personally administer more than 49 million anesthetics to patients each year in the United States. CRNAs also provide acute chronic management services. We recognize the challenges in MVP design and implementation, especially for providers such as CRNAs. For example, as the promoting interoperability performance category is a key structural part of any MVP, we note application of this will be problematic for clinicians such as CRNAs who currently do not participate in the promoting interoperability category because they are included in the automatic reweight to the quality performance category in MIPS. Also, there are very few cost measures available to anesthesia providers, such as CRNAs. The available measures are generally tied to the surgical procedure and not the anesthesia services CRNAs provide. So we offer the following feedback with respect to the subgroup reporting options. We support the concept for subgroup reporting for MVPs and that subgroup reporting remain optional for all clinicians. Many CRNAs participate in multi-specialty group and the current measures do not adequately represent our anesthesia providers. Making subgroup reporting mandatory is an unreasonable demand on providers. Forcing providers into a mandatory system disincentivizes them from participating in the program. We support option one, having additional time to submit the identification information for subgroups, even though subgroups would be assessed on less information from the subgroup for the subgroup identification and election process. This allows the flexibility for CRNAs, even if they are assessed on less information. We also support option B, subgroup scores are rolled up into this group's final score to result in one overall final score for the group. The subgroup score may or may not be weighted as part of the group's final score. We believe it would benefit CRNAs more by having subgroup scores rolled into the overall final score for the group. Currently, anesthesia did not have enough relevant measures required for the MVP. CRNAs need to be multi-specialty groups to successfully participate in MIPS and going forward in MVPs until proper anesthesia measures can be developed. Appreciate clarification from CMS on how it envisions using QCTRs to support subgroup reporting. We offer the following feedback with respect to MVP design. We believe CMS should prioritize creating MVPs where alternate payment models don't exist so that we can lay the groundwork for a future APM that proactively includes and recognizes the needs of anesthesia. There is no APM for anesthesia providers to meaningfully participate in. We would ask that CMS please include ANA in future discussions and development of meaningful MVPs and APMs moving forward. We stand ready to work with CMS on this important work. Regarding the question on what element of APM design might CMS consider in developing MVPs, we believe that similar quality and cost measures and improvement activities that adequately represent both surgeons and anesthesia providers will help CRNAs participate more meaningfully in APMs. For many CRNA setting, anesthesia cannot be separated from surgery. We ask that CMS recognize this dependent and collaborative relationship. With regard to the question on how CMS should ensure that MVPs are meaningful to specialty clinicians that have limited applicable APM models available to them, we offer the following recommendations. First, we ask for CMS assistance in helping clinicians choose MVPs that apply to their specialty while making participation in them voluntary. This is vital because CRNAs who are not part of a multi-specialty group or who provide anesthesia for a wide variety of procedures will not know what MVP they should participate in. These could include CRNAs who are solo practitioners or those who work in multiple TINs. We ask for educational tools that will help clinicians evaluate the available options. Second, the ANA asks for direct involvement in the vetting of candidate measures for MVPs by specialty societies, especially those involving anesthesia and pain management. If MVPs involve anesthesia or pain management measures, there will be major implications for anesthesia providers such as CRNAs. It's imperative that our association have input into the development of these MVPs and measures, even those not submitted by our organization. We offer the following feedback with respect to MVP reporting requirements and scoring. We are concerned that the feasibility in participating in MVP, especially for clinicians such as CRNAs, who do not have applicable cost measures and who currently do not participate in the promoting interoperability category because they're included in the automatic rebate to the quality performance category in MIPS. And that wraps up my comments. Thank you again for the opportunity to participate. We welcome further engagement with CMS beyond this town hall and stand ready to work with CMS in finding innovative solutions to the challenges faced by CRNAs. And thank you, Gab.
Great, thank you, Ralph. All right, next we will go back to Jennifer from the American Medical Association to provide your feedback. So Jennifer, we've unmuted your line and you have your 5 minutes.
Good morning, thank you, and apologies for the technical hiccup a few minutes ago. I hope everyone is able to hear me. Thank you so much to CMS for hosting this MVP town hall. We're really glad to see that there's a lot of interest and a lot of engagement, and are happy to provide our comments about the subgroup reporting option. And these comments will be specifically focused on session 1 and the comments that Molly went over. So regarding the subgroup reporting option, the AMA does reiterate its support for a voluntary subgroup reporting option that would facilitate participation in MVPs. The AMA has heard from physicians and specialty societies who recognize that specialists who are part of a group practice would like to be able to report separately from the larger group and partner with their colleagues in the same or a similar specialty to report on MVPs that are more clinically relevant to that particular specialty. The AMA strongly opposes making subgroup reporting or participation in an MVP mandatory, and the AMA also does not support requiring participation in an MVP at the subgroup level. Physicians and clinicians who are interested in participating in an MVP should have the choice to participate as individuals, as part of a subgroup, as part of a virtual group or as a group. Regarding subgroup identification and the election process, the AMA encourages CMS to align MVP registration with the subgroup reporting registration process to streamline both elections and minimize administrative burden. We believe physicians may need greater flexibility and time to elect to form a subgroup in the initial years of this reporting option and of MVP to identify the appropriate members of the subgroup and to form the subgroup. Regardless of the timing of the subgroup election, we urge CMS to ensure it is a streamlined process similar to the CMS web interface or CAHPS for MIPS registration. We do not believe it is necessary to replicate a process as cumbersome as the virtual group agreement process for subgroups interested in MVPs. Subgroups would be members of the same TIN, unlike virtual groups that may be comprised of different groups coming together to form an agreement to jointly participate in MIPS. CMS also asks about subgroup reporting, and regarding those questions, our comments are that CMS has an established process for physicians to report ECQM information along with MIPS performance. The technical architecture for this process is managed by HL7 and further modified by CMS. TIN and NPI information is tightly integrated within CMS's guidance, and MVP reporting will require adjustments to this architecture. Including new subgroup reporting identifiers will require modifications to HL7's base standard and CMS's guidance. The time to make the necessary changes and test health IT systems against the new updates will directly impact when third-party intermediaries, EHR vendors, and physicians can adopt subgroup reporting. Changes will also impact intermediaries' reporting of MVP performance categories on behalf of physicians. Physicians will also need new workflows and dashboards to support MVP reporting. With the addition of a new subgroup identifier, EHRs will need to support a process for physicians to self-select subgroup membership, to track unique users across PI, quality, and IA performance categories, to develop new MVP performance dashboards, and to account for changes to subgroup rosters when physicians leave or join subgroups. We believe CMS should also consider validating MVP data submissions, supporting practitioner subgroup rosters, and aligning subgroup reporting with ONC's 2015 Cures Update ECQM requirements. Finally, regarding subgroup scoring, physicians in the group who are not affiliated with an MVP subgroup should retain the option to participate as a group practice in traditional MIPS or to select another MVP. We urge CMS to look to its split TIN policy for certain advanced APMs, where some of the clinicians billing under the group's TIN participate in the model while others do not. In this case, the portion of the group not participating in the model has the option to participate and report in MIPS as a split TIN and be scored via another data submission mechanism. This will minimize the burden on multi-specialty groups that have a subgroup interested in an MVP. Thank you for your consideration of these comments.
Great, thank you, Jennifer. All right, as a general reminder to everybody who would like to give feedback on the line, we do have 3 different sessions today with 3 different feedback portions. So this one currently is focusing on MVP subgroup reporting. So we do ask all participants to keep that in mind, and again, to keep your comments to around 5 minutes to ensure that all those who'd like to speak have the opportunity. All right, so next we have Kevin Wang. Kevin will be speaking from the Hospital for Special Surgery. And Kevin, we're unmuting your line. You may go ahead.
Hi, thank you. My name is Kevin Wong. I'm Senior Director for Performance Programs at Hospital for Special Surgery, and I want to thank CMS for hosting this town hall and the opportunity to provide feedback. I think, first of all, HSS would like to applaud the concept of subgroup reporting, as previously the lack of subgroup reporting has been a reason why physicians as a specialty hospital or specialty physicians have had to select for independent reporting at the individual NPI level rather than at the 10 level or virtual group physician level. I think some of the feedback that we have is that as these MVPs become go into production, whether or not there will be thresholds for subgroups to elect into an MVP. So for example, if there was a hypothetical low back pain NVP, and physicians such as physiatrists or orthopedic surgeons perform procedures on a different proportion of patients with low back pain. What would be the threshold for electing into that? Is there a minimum threshold required, or would it be a voluntary self-selection? And so at that point, would an orthopedic surgeon who only treats a patient population of 15% with low back pain be equivalent in that MVP to a physiatrist who treats a population of potentially 60% with low back pain? I think some of the other points of feedback are around further clarification of how NPIs can elect to be a part of a subgroup. For example, if a hospital has multiple TENS as part of its structure, and there are physicians across TENS who would like to form a subgroup, how would those NPIs potentially cross into it? Would it be something like the virtual group practices and the mechanisms for electing into that? Further clarification would be much appreciated as part of that. And then finally, how would the subgroup data be displayed on public sites for patients, and how would patients understand the performance of a subgroup using websites like CareCompare or Physician Compare? It's unclear to us whether or not it would be beneficial to patients if a physician was individual versus overall. And finally, we agree that as of now, it should not be mandatory in order to keep the burden at a reasonable level. All right, thank you very much.
Great, thank you, Kevin. Okay, next we will move on to Aisha Shkola from the U.S. Anesthesia Partners. So Aisha, we are unmuting your line and you may go ahead. Aisha Shkola, you are currently self-muted. Yep, you may go ahead.
Okay, great. Thank you so much. We appreciate, being able to give feedback. I think just because we are a single specialty group, I would like to say that it doesn't, the subgroup category would not relate to us, but if in the future, if it did, we would also like to say that we would, we'd want it to not be mandatory, and we would also like to say that further measures related to anesthesia practice would be much appreciated, and we would be, very inclined to help out in that discussion with CMS. Thank you.
Great, thank you, Aisha. All right, next to speak, we have Lori Johnson from University Physicians. So Lori, we've unmuted your line. If you would like to self-mute, you may go ahead.
Hi, good morning. Thank you for the opportunity to give some feedback. In regards to subgroup formation and MVPs, overall, I am in favor of the concept. However, I am not in favor of anything that is mandatory for providers and doesn't give providers choice. One of the things that I thought might be problematic is when I read the town hall preparation guide, is that if you select to do subgroup reporting and then you also elect to do overall group reporting, that the subgroup NPIs would be included in your overall group reporting. As I think about the measures and the example that you gave of the surgery group doing subgroup reporting, if those surgeons were also included in preventative measures, if those are the measures you chose for your overall group reporting, including those patients that may not be seen in primary care at your overall group, but are seen in the surgery specialty practice, would dilute your performance in your overall group performance. So I am in favor of allowing the NPIs that would report as a subgroup to be excluded from your overall group reporting. Otherwise, your overall group reporting is going to be more of a reflection of the makeup of your specialists, of the specialties that are in your overall group practice, than really and your measure selection, than your overall measures. The other part is with the group reporting or the formation of subgroups. I feel like option 1 is the best way to give your participant list because of when residencies complete and onboarding processes. We tend to onboard the bulk of our providers in an academic medical center at the last half of the year or from July on. We would end up having to, if it was the July 1st cutoff, I think we would have to do individual reporting, perhaps subgroup reporting, and then overall group reporting to ensure that all of the NPIs in our 10 have reported successfully for that year. If you couple that with also tracking whether your providers have qualified as a QP in an APM, it's a lot of contingency plans. And if you think about quality reporting, none of those are without cost. So if you have to have multiple collection methodologies, so a QCDR, a specialized registry, an ECQM, all of those have technical implications of implementation, and they also have cost associated with them. So it's hard to use, it's expensive and burdensome to use multiple collection types for a single multi-specialty practice. I think that are the only comments that I have about subgroups, but thank you again for allowing me to provide my comments.
Great, thank you, Lori. All right, next we have Brian Bamstead. Brian will be speaking from Alina Health. All right, and Brian, if you would like to unmute yourself, you may go ahead.
Good morning and thank you. This is Brian Bamstead, Manager of Regulatory Affairs for Alina Health. We are a large multi-specialty organization of about 90 clinics, 11 hospitals, and we are headquartered in the beautiful state of Minnesota in Minneapolis. A lot of the things that we were going to raise in these comments have been raised already, and just at the high level, we'll note that we understand where CMS is coming from and cognizant that they're trying to achieve simplicity and flexibility, and they're sometimes difficult to accomplish in tandem. And also you throw in this pandemic that we've been working and trying to combat over the past year, and that has been extraordinarily challenging. So we first of all appreciate the flexibilities that CMS has allotted in this area over the course of the last 9 months. We really appreciate that. I think that's important as we continue to move forward. Overall, we will reiterate our support about voluntary MVP participation. Thank you for highlighting this. We think that this is really important. Healthcare organizational structures, as you know, for providers, they vary widely across our country, from small groups, individuals, employed, non-employed, and many professional service agreements. So you have the interaction of the TIN and MPIs and the various combinations. They also vary. So a one-size-fits-all is just, not really going to work. Mandating and assigning MVPs would, unfortunately for us and many others, create administrative challenges that I think would be counterintuitive to the goals that you're trying to achieve. And as such, as one of the things we'd highlight too is that group level reporting must be maintained as a pathway. Requiring some subgroup reporting would unfortunately add additional administrative burden that is a very big concern for us. And we think that voluntary participation will help leverage the measure sets that may be most appropriate for a type of group. I think one of the commenters earlier mentioned about, what if a subgroup wants to pilot something or try something? That's fine, but it's important to maintain that as a voluntary activity to move for an MVP space. And again, as we are focused on as part of our strategies about population health and trying to drive improved community health, we have a recent agreement with a large major insurer to really dive into the space. We're concerned that if you adding these MVPs may be counterintuitive to that strategy. So maintaining that group level and maintaining MVP as a voluntary approach will be very important so that we can move in the direction that we want to and can for improved population health. So those are our top line comments with subgroup reporting, and appreciate the opportunity. And thank you so much for hosting this today.
Great, thank you, Brian. All right, that concludes our scheduled feedback session. In a moment, we will turn it to our open feedback session, during which you can express interest to provide a comment over the phone line by toggling the green hand icon on your go-to menu. Just before we do that, we will turn it back to Molly McHarris to go over a bit of the feedback provided today.
Thanks, Lauren. And thank you again to everyone who has provided feedback so far, and very much looking forward to additional feedback that we'll be hearing in a couple of minutes here. So I just want to reflect back some of the feedback that I've been hearing from the notes I've jotted down. So I'm hearing overall a really large theme, I think from everyone, that as we think about moving forward to MVPs overall, but specifically for subgroups, it has to remain voluntary. So I just want to reflect on that. I don't think I heard anyone say that they feel as we move to MVPs that they should be mandatory. And I don't think I heard anyone say that as we move to MVPs, subgroup reporting should be mandatory. So that's one clear theme that we've heard. When we open it up for the open feedback, if anyone has comments on that would disagree with that kind of overarching theme I reflected, please feel free to provide that feedback to us. Otherwise, we'll take that down as one of the major themes we heard here. I did hear a little bit of back and forth on some of our questions on the way that the subgroup identification should occur. I heard overall of the themes that we want this process to be as simple and straightforward as possible, and to follow some of our existing straightforward registration processes such as web interface and CAPS, and to not use one of our more cumbersome registration processes such as virtual groups. But I believe I didn't hear any, or I didn't hear full alignment on whether or not we should go with option 1 or option 2. That is okay. But if folks have other feedback on that approach, that would be great for us to know as well. And so with that, and so of course there was a lot of other great feedback that we heard from that open, or from that feedback session. But just to help us as we go into the open feedback session, I do want to go back a couple slides. So let's go back to slide 12. Okay, so I believe Lauren, let's go back to slide 11. So for these, I just wanted to reshare them. So for this slide, I believe we heard a lot of feedback on this one, but again, if there's any additional feedback that folks have on the timing of when the list should be made available to us, we'd love to hear that. This really helps us as we're thinking about, again, think back to what Michelle said at the onset, that everything that we're thinking about here today, this will help inform our proposals. So if folks do have any more feedback on these various options of the timing of when we would want to have the participant list, that just helps us as we think about what proposals we would want to move forward. So I did hear feedback on this one, but just wanted to reflag it. Let's go ahead and move to the next slide, Lauren. Because this first question, I didn't really hear anyone comment on. So the question of whether or not we should maintain the subgroup identifiers from year to year. So just curious if folks do have any feedback related to this one. And then let's go ahead and move on to the next slide. So yes, I believe we did hear some feedback on that we should go ahead and update our specifications to account for subgroup reporting. I would like to get some feedback on whether or not folks feel that we should take it to the level of adding subgroup reporting to our certified EHR technology requirements. So curious if folks have any thoughts related to that. And thank you for those who did give us your preliminary feedback on the promoting interoperability performance category, but anything more that folks want to share there, we'd love to hear it. And then Lauren, let's just go to the last slide one more time. So this first question, for subgroups receiving their own final score or have the subgroup score rolled into the group's final score. This was another area where I'd also like it if folks could give a little bit more feedback here from those who are able to share their thoughts thus far. And again, thank you for all of this. We will be collating all of these notes and we'll be taking a deeper dive of all of this. To the extent there is any more detail folks can provide on the approach of how we should actually calculate the subgroup score. Again, should it be an independent subgroup score that exists separate and apart from the group, or should it be aggregated? I heard feedback, at least from my notes, that seemed to reflect support for both of those options. So just interested if other stakeholders that are on the call today have other feedback. Let me stop there. And just before we open it up for other general feedback, I just want to stop and see if any of our other panelists of our other CMS folks wanted to comment on anything. Okay, so Lauren, I think we can open it back up for further feedback. And yes, please keep it coming. This is really, really helpful as we are working through this. So I will be quiet again. Thank you.
Great, thanks, Molly. Okay, again, if you would like to speak over the phone line to provide more feedback, please toggle the green hand icon on your go-to menu to flag your interest, and we will call on you to unmute your line. So first up is Trudy Piercy. Trudy, we will go ahead and unmute your line. If you'd like to also unmute yourself, you may go ahead. Please provide your name and organization when you start speaking.
My name is Trudy Piercy, and I'm with the University of Iowa Healthcare and Clinics. And we're an academic medical center with a nationally ranked oncology and cancer center. We also have a significant sized children's hospital. We also host our EHR for quite a few Community Connect partners. So our breadth is across the state of Iowa and beyond. And the MVP constructs that you've put forth in option 1 and option 2 are really mind-boggling to me in what we do for our state and outside our state. We have people that come to our state from around the country, sometimes out of the country, for our specialties. So I understand and I value the thought process you're putting into the MVPs for subgroup reporting. It makes complete sense from a federal perspective and possibly from a patient perspective who might be wanting to look at a physician compare site. Those things make great sense to me. However, as what is mentioned before, the lift to accomplish this for an institution of our size is astronomical. And I think that option 1 is the timing of when we'd identify those subgroups is appealing. Option 2's timeline isn't realistic for us at all because we're an academic center. We have medical students who might be done in May or might be coming to us in the fall, and fellows come in and out all year long. So the timing of those two, we'd go with option 1, but the granularity of what measures, then it'd be option 2. To expect our EHR to have the certification on all these measures, whether they're ECQMs preferably, that is a heavy lift on their part as well. Again, a little bit mind-boggling for me. So I think that if CMS wants to pursue these MVP models, I think they need to provide some monetary incentivization ahead of time so that we can invest in the infrastructure to do this, that we can't just add the burden onto what we're already doing, especially when economic times are tight already in the academic world. And again, thank you for this forum. It's awesome. I find them very useful. And that's all I've got.
Great, thank you, Trudy. Okay, next we will turn it to Erin Solis. Erin, again, if you would like to unmute yourself, you may go ahead. Please provide your name and organization to start. Erin Solis, if you'd like to unmute your line, you may provide your feedback.
I'm sorry, I'm unmuted by accident, or must have raised my hand by accident.
No worries, thank you. All right, we will move on to Joshua Cartwright. Again, Joshua, we will unmute your line. If you'd like to unmute yourself, you may go ahead.
Yes, good afternoon. Thank you for this opportunity. My name is Joshua Cartwright. I'm Director of Quality Programs and Performance Measurement with Presbyterian Healthcare Services in New Mexico. I would like the opportunity to comment on the should we add subgroup reporting to the CERT requirements. From a large healthcare standpoint, our CERT or our vendors, I would just like the opportunity to share that when we have a new requirement that's rolled out, whether you report at a large 10 or an independent, as an independent provider under the regular MIPS program, we have to set up the provider records every year. In addition to that, to set up a subgroup or a specialty requires a heavy lift or build on the back end. And each year we also have, our vendor is Epic, we use their out-of-box or ONC certified CMS deliverables to review performance. And that actually occurs after your standard update or upgrade every year. And so there's a cadence schedule that's already established, generally 12 months out. And so an expectation or even a mandatory requirement that subgroup reporting separate from your large group based on CERT requirements would be burdensome. Thank you for the opportunity to share that.
Great, thank you, Joshua. Okay, again, if you would like to provide your feedback on subgroup reporting with MVPs, please toggle your interest by raising your green hand icon on your GoTo menu. We will give it a few more minutes for a few more hands to be raised. Okay, all right, Lori Johnson from, I believe, University Physicians, we will go ahead and unmute your line and you may go ahead.
Hi, I just wanted to add a comment that I feel that subgroup score should not roll up to the overall group score just because of complexity. And I think if it does roll up to the overall group score, it kind of negates the purpose and the intent of subgroup reporting. So if you elect to have subgroups, they should be able to stand independently. However, when I say that, it really pertains mostly to the quality category. I understand that cost and some of the administrative claims measures may be applied to the subgroup at the overall 10 level, which I'm fine with that. And I also feel that the promoting interoperability measures, it's fine to apply the overall group performance for promoting interoperability to the subgroup. As far as CERT requirements for subgroup reporting, I'm a little on the fence. I think it would be helpful as that would necessitate EMR vendors developing the software. As it currently stands in our system, we wouldn't be able to tease out subgroup reporting. We have 10-level reporting and individual level reporting for promoting interoperability as well as the quality measures. So there would have to be some technical rework in order to be able to support subgroup reporting. But for quality reporting, some of the systems that are used for quality reporting are not part of certified EMR technology when you start thinking about QCDRs and registries. So I don't have a great recommendation on whether it being included in CERT would be helpful or not. I'm leaning towards yes, as we would have some development, at least from EMR vendors. There would be an expectation that they develop that capability. Thank you.
Okay, thank you, Lori. All right, next we have Jill Sage. Jill, if you'd like to unmute your line, you may go ahead.
Yes, thank you. Hi, I'm Jill Sage. I'm the Quality Affairs Manager with the American College of Surgeons. Just a couple things I wanted to add to the discussion. So, you know, some of the strategic direction that MVPs is looking to take is to engage patients through patient-centered policies, and two, to reduce the barriers to APM participation. And one issue I just wanted to raise, that I think that, you know, especially in light of the subgroup reporting discussion, that a lot of this discussion is still very much in fee-for-service think. We're talking about measuring the surgeon different from the anesthesiologist and so on. And I really think that the discussion would benefit from thinking about it from more of a transition towards APMs, which is going to be focused on the patient, that's going to be focused on the care team, and really how all of those pieces can align to then get towards that APM goal. And also, that would be looking more at a patient-centered approach. Another thing is testing. There's so much discussion, and there's just a lot of factors as we think about how subgroup reporting would actually happen when implemented. As I think that's pretty obvious during this discussion today. And I just think it strongly suggests that it's important that this be tested on some level. There's so many questions, especially about attribution methodology, and this is not currently in the MIPS program. So in practice, we don't know how this is going to actually work when it's implemented. And before rolling this out on the national level, I just think that if that's a possibility, seeing what is feasible in terms of subgroup reporting is going to be critical. And I agree with one of the other commenters that was really worried about sort of the financial issues in implementing subgroup reporting, and thinking about how incentives can be thought about to encourage participation in MVPs, especially if they're going to be voluntary. So I just wanted to, emphasize the importance of that as well. Thank you.
Great, thank you, Jill. Okay, next up to provide feedback is Jason Shropshire. So Jason, we will go ahead and unmute your line if you'd like to go ahead.
Hi, can you hear me?
Yes, we can.
Hi, thanks again for hosting this as well. And I just want to, first of all, I'm the manager of the MIPS program for UNC, University of North Carolina Healthcare, which is several hospitals and physician groups across the state. And I just want to echo basically what everyone else has stated, that subgroup reporting should not be mandatory, especially for large multi-specialty groups, because the administrative burden will increase dramatically. It's just not feasible without greater, huge expense to these healthcare systems, because they're going to have to hire additional staff, both from the administrative side as well as information security, because they're going to need much more help to develop more measures. So I completely agree that it should be voluntary. And also to the question of the option 1, 2, my suggestion would be CMS often, if a physician submits data in more than 110, typically CMS will take the higher score. So my suggestion would be, as they're working out the kinks of subgroup versus group reporting, that the final score for a subgroup, if they choose to report that way, would be the higher of whatever score they achieved for either their subgroup or as their final group, at least for the first 2 to 3 years, while we know there are going to be many administrative, again, kinks to work out. Thank you.
Great, thank you, Jason. All right, next we have feedback from Suzanne Joy. So Suzanne, if you'd like to unmute your line, you may go ahead.
Hi, yes, thank you. I wasn't planning to comment in this session, but just a couple of things other participants said I would love to add on to. I work for the American College of Physicians, and we very much appreciate this opportunity to provide feedback. Just a couple of quick things, just kind of, again, support and echo what everyone else is saying about, strongly opposing any sort of mandatory subgroup reporting, but generally supporting the option as more flexibility and more reporting options is better and allows for more tailoring of reporting so that it can be more clinically relevant to various different patient populations and specialties. And I just wanted to point out, I know CMS, one of their big goals with that is, of course, giving more specific data and feedback to clinicians. And I don't think any of us don't appreciate that. I think there's a difference between being required to report, national data and getting your payments adjusted on it, which is what everyone's concerned with, and that administrative burden concern. And then there's a question of data. And I think you can definitely provide data at the sub-10 level without requiring perhaps reporting at that level. So I just wanted to kind of draw that distinction and add that I also very much like the idea and strongly support, and ACP has been supportive of this in the past, of Jason's point about using the higher of the two scores, and there is precedent for that with the way CMS handled the facility-based scoring, which we were strongly supportive of. So again, appreciate the opportunity and looking forward to today's continued discussions.
Great, thank you, Suzanne. All right, again, if you would like to provide feedback on subgroup reporting for MVPs, you may do so at this time by raising the green hand icon on your go-to menu. In the meantime, Molly will pass it back to you for any more thoughts.
Okay, thanks, Lauren. And thank you again for all of the additional feedback that we've heard here today. Really great feedback. This is really, really helpful as we are thinking about, again, what our proposals would look like as we work to move MVPs, but specifically subgroup reporting forward. I believe now that we've hit on the vast majority of our questions. Let me see, I think the one question, and I'll target this, so if we want to hop to slide 13, I think the one question that I haven't heard a lot of feedback on, and this would really be if we do have any of our third-party intermediaries on, because we have heard this from our folks from the university healthcare systems, from the academy system. So thank you for your feedback. But the question that I am thinking of is our first sub-bullet here. So do third-party intermediaries and practices believe they can manage supporting subgroup reporting over the short and or long term? So again, heard a lot of feedback from the healthcare organizations themselves, and I'm hearing there are, again, the overarching theme that while we like the concept of subgroup reporting, in no way, shape, or form should it be mandatory. And I've also heard a number of comments from folks that there would be financial implications as we work to move subgroup reporting forward. And then also thank you for those who gave us feedback on what the updates to your certified EHR technology, what that would look like. But I am curious if we do have any of our third-party intermediaries on any of our EHR vendors themselves, or any of our QCDRs or registries who may want to comment on this question. And then I think at this point, this will probably be the last time that we pause for questions on the subgroup topic. So again, any targeted questions from responses from third-party intermediaries on their thoughts of subgroup reporting. And then this will be the last call for any general feedback on this topic before we go ahead and move on. So let me stop there again, and I'll turn it back to you, Lauren.
Great, thanks. Just to reiterate, in the time we have left, if you'd like to provide feedback, go ahead and raise your green hand icon. We will not be looking at comments received over the chat box at the moment, so do recommend providing any comments over the phone line. Okay, first up, we will pass the line over to Devin Gentilesco. So Devin, we'll unmute your line. If you'd like to unmute yourself, you may go ahead. Go ahead.
Hello, my name is Devin Gentilesco, and I'm with Cerner Corporation. Some quick feedback that I would give. I'm confident that we could support the concept of subgroup reporting. My concern would be more along the timeline. So I've heard most physician groups voice support for being able to define those subgroups as late in the year as possible, or even into the submission period. So just thinking through defining those, when is that identifier going to be available? That would then have to then, excuse me, be defined in our system. Then we would have to aggregate all the data, create the submission file, and get that submitted. And that seems like a lot to do within a 3-month period. So conceptually, yes, I don't see a problem with supporting subgroups, but it's more along the timeline that I have concerns.
Great, thank you, Devin. Okay, next we have Donna McCarthy. Donna, we'll go ahead and unmute your line, and you may go ahead and provide your feedback.
Hi, this is Donna McCarthy from Lawrence Memorial Hospital in Lawrence, Kansas. I hope you can hear me okay.
Yes, we can.
Perfect, thank you. We are a small community hospital, a standalone system. We've been participating in MIPS since it began. We think we have our process down pretty well. And we've made it as efficient and effective as possible. I would say we agree with the concept of needing specialty group reporting. And I'm sorry to say, I don't know that I have an answer as to how to go about achieving this, but I know that I feel strongly that this current process is not going to work for us due to the increased burden and the resources that we have available. So while I don't have what I think is a good answer or a good solution or insight, we would struggle with the proposal as it is, with all aspects of it, the overhead. We have, I think, about 17 specialties in our reporting tin. So this is it just kind of blows our mind about how we would go about achieving this. Anyway, just our perspective from a small community hospital, and I appreciate the opportunity to share that perspective. Thank you for doing this town hall. It is a wonderful format.
Great, thank you, Donna. Okay, next we will go to Christina Nardi. Christina, we'll go ahead and unmute your line. So if you'd like to unmute yourself, you may go ahead. Christina, you may go ahead. Okay, we will circle back to Christina if she'd like to give comment at a later date. In the meantime, we have Judy Burleson. So Judy, we will go ahead and unmute your line, and you may go ahead and provide your feedback.
Hi, can you hear me?
Yes, we can.
Okay, thanks. This is Judy Burleson with American College of Radiology. From our perspective as a qualified clinical data registry, which is a functionality of our overall National Radiology Data Registry. It's just one component of that registry that I'm getting feedback. Can you still hear me?
Yes, we can. We'll go ahead and try to mute that background noise, but you can go ahead in the meantime.
Okay, thanks. It's somewhat similar to implementing the virtual group capability, and I think from a conceptual standpoint that we would be able to do that as a third-party intermediary, a QCDR. It would require additional functionality, additional layer of structure to the facility group 10 NPI structure. Functionality across all steps in the reporting process would need to be implemented to aggregate the data appropriately and to report it. We would have to prioritize development of that capability along with our existing QCDR and non-QCDR related registry needs. There would be required testing to make sure that it works appropriately. It's not a small effort in terms of education for our participants and how to do it, how it should work, the ramifications of it. So I would say minimum a year in development. So it is not a small undertaking. And there is definite resource issues in terms of cost, programming, development, testing, staff resources all involved in the implementation of it. So thank you for the opportunity.
Great, thank you, Judy. Okay, again, we do have a bit more time for feedback. So if you'd like to provide any feedback, again, we will not be looking at comments sent to the chat box. So please raise your hand to share anything over the phone line at the moment. If not, in the meantime, while we wait for a few more speakers, Molly will pass it back to you.
Okay, thanks, Lauren. Just a couple other questions, comments I wanted to flag just as I've been reviewing some of my notes, and my team as well. We've been reviewing our notes from the feedback we've heard so far. And again, we want to try to ask some of these questions now, since we are at a time where we can really have this discussion with you all when we're not in our rulemaking cone of silence. As those of you who work with us frequently know, we often get into those time frames. So there are a couple follow-up questions I'd like to ask based off of what we've heard today. So one is focusing on some of the comments we've heard about burden and incentives. So I've heard from folks today that conceptually people are in favor of subgroup reporting, particularly voluntary subgroup reporting for MVPs, but we've also heard about the burden given how new this is. And I did comment that we do anticipate and understand that there will be an increase in burden as we make this transition. So as we're thinking about that, and as we try to work through various trade-offs, and as we think about wanting to still move forward in this direction, since we do believe that it will be beneficial, and what we're hearing from all of you today is, yes, there is that concurrence, but also concern on how we implement it. So my follow-up question that I'd like to hear some additional feedback from folks on, if they have any that they can share today. If not, if you don't have anything ready to share today, I'd ask that you include any additional feedback on this question in your written comments. So as we think about that transition and that movement, what could we be thinking about to incentivize groups to initially form subgroups for the initial years? And I do want to add a little bit more context to this question, because oftentimes when we ask that question to stakeholders as, you know, what incentives or what can we do, we get responses of give more money or give a lot of bonus points. And I just want to provide a little bit of feedback on those two responses. So for the issue of giving an additional, bucket of money, or potentially holding people harmless if they chose to do this option for the initial years, that is something that unfortunately we cannot do. We have received that request really since MVPs came about, and we have taken a look at it really at every angle. And unfortunately, that's just not something that we are able to do based off of the way that our statute is constructed. So again, we do not have the ability for clinicians who would voluntarily report an MVP or a subgroup MVP to quote unquote hold them harmless from any negative consequences, meaning any negative payment adjustments from the MIPS program. Some of the other comments that we hear as well are, let's give extra bonus points or another bucket of money. For the money item, it's similar to what I was just discussing, that unless the way that our programs work is that unless we actually have a line item allocated to us, we cannot issue those additional funds. So while that is something we would be interested in, unfortunately, it's not allowable. And then for the last comment that we typically receive of, just include a lot of extra bonus points, that is something that we are open to and we would be interested in considering. I do want to flag, though, some of our concerns with introducing bonus points is we want to ensure that we are incentivizing the right things and that we don't have so many bonus points that it creates what we call score inflation or masking poor performance. So we, ideally want to be assessing clinicians, groups, subgroups based off of their actual performance on the 4 performance categories, and we don't want to overly inflate that too much with our bonus points. Our other concern is while we also worry about in a future state on trying to remove those bonus points. because we kind of view them as training wheels, and we do understand that once folks get used to the training wheels, taking those off can be a bit difficult. So that was a long-winded question. I apologize for that. But let me pause there to see if folks have any other thoughts or feedback they'd like to share with us on ways that we could incentivize groups, but also taking into consideration some of those items I had just flagged. So I will pause there again to see if there's any thoughts or reactions.
Great, thank you, Molly. First, we'll pass it back to Trudy Piercy to go ahead and provide your feedback. Trudy, you may go ahead.
As far as the funding, you know, and the heavy lift of it, again, we're an academic medical center that is, you know, huge, and we'd have so many specialties, and there'd be so many subgroups. The funding, if you do the points or if you do the back end funding models, it's still the institutions are taking on the financial burden ahead of time without ever knowing if they're going to get any financial benefit in the long run. And in these financial times, we just can't afford to do that. Our margins don't allow us to just have to hire some FTEs to do this reporting, because when you have many specialties and all those many subgroups, the number of IT people who would have to do the configuration of the software, and like the other speaker mentioned, the cadence. We too are an Epic user, and the cadence of the upgrades from Epic in relative to the measures. And another speaker mentioned of the multi-submission modes. Again, there's so many things to juggle. The volume of staff upfront needing to be hired is long before any points are allocated during a pointing system or payments are adjusted for rate performance. So I think I would encourage the government to consider doing front-loaded mini grants per specialty, per MVP. And then still optional, if they don't want to do it, you don't apply for the grant. If you apply for the grant, the expectation is you do something and you will submit the data, not whether you won't be held accountable for the rate of the data, but just the data. And relative to third-party intermediaries for these kinds of things, as a huge academic center, we, and as of the recent cyber attacks on healthcare, we're trying to reduce the volume of patient-level data in third-party hands. So that's, again, something to think about, that's that burden that we're taking on, that we need that front-loaded funding model. Again, thank you. That's all I've got.
Great, thank you, Trudy. Okay, next we will pass it to Donna McCarthy to go ahead and provide your feedback. Donna, you may go ahead.
Hi, Donna McCarthy again. Thank you. Really not much to say, except I think that was Trudy that just spoke, and I just want to say what Trudy said. Even though she's from a large academic organization and we're a small community hospital, she expressed many points very eloquently that we are in agreement with. So thanks, Trudy, appreciate it. And that's all from here. Thank you.
Okay, thank you, Donna. All right, next, Joshua Cartwright, you may go ahead and provide your feedback.
Thank you, Joshua Cartwright again with Presbyterian Healthcare Services. I agree or concur with the financial incentive conversations or suggestions that have already occurred. Additionally, I wanted to propose, and I don't know if there's an opportunity to obtain feedback from the CMS panel today as far as incentive, but there was mention earlier of the opportunity to take the better of the two and the discussion of precedent, because that does occur with TIN reporting. If you do have providers reporting at the independent level or individual level as well. So that's a great incentive. And with that, I would also like to propose or suggest the discussion of reputation. In 2019, the MIPS public reporting occurred on scoring. And so it could be very incentivizing if there was an opportunity to submit your subgroup data without the penalty of potential negative public reporting as we work through the administrative aspects of this new program. Thank you.
Great, thank you. Okay, next we have Trisha Conway. Trisha will go ahead and unmute your line. If you'd like to go ahead and unmute as well, you may go ahead and provide your feedback.
Thank you. My feedback was actually for the last topic, so I don't know whether it's okay for me to give that now or if you'd rather me hold it.
You may go ahead.
Okay, thank you. So just in general, again, Trisha Conway, I am representing eHealth Consulting. We work with many multi-specialty practices across the United States, and subgroups are so needed. So I'm definitely in support of those and can't wait for them to be worked out, rolled out. So that's great, and I appreciate the opportunity to give feedback. I wondered about, you know, the implementation of subgroups, if perhaps the 10 APM logic could be followed with respect to setting up identifiers, the registration process, attributing the NPIs to the specialty identifier. And an example would be, so if we have a subgroup that registers, let's say, as of 7/1, so obviously I support option 2, and they have another provider that joins that specialty, which is a subgroup, right, after 7/1, then it seems like it would be easier to incorporate them if that same logic or process were followed, because that one seems to work really well. So I just wanted to throw that out there so it could be considered. The other comments would be that I don't think that it is a good idea to incorporate the score of the subgroup into the final score, because the goal here is to track the performance and, you know, really incentivize the specialists to embrace the quality metrics that are most applicable to them. And I think if you just toss their score into the overall score, in some ways that decreases their motivation in doing well, because they're not operating as their own entity. And, you know, they really need the opportunity to use the quality measures that are most applicable to them. In addition to that, I think it's important for the certified EHR technology to be responsible for participating in the subgroup methodology. And if you look at the quality measures that are currently part of this ECQMs, there's still not a lot of specialty measures that EHRs are able to calculate. And so that is certainly a problem for, you know, for implementing the MVPs. We would need to make sure that there were enough quality measures that the EHRs are able to aggregate in order to support the subgroup participation. So making that part of the certified EHR technology process with ONC is an important piece of that. And along those lines, I do agree with Devin and others that have said that we need sufficient time to be able to roll this out. You know, once the MVPs, the concepts are identified, then, you know, that has to be translated into what's needed for the certified EHR technology or the third-party vendors that are submitting information. It needs to be, you know, kind of executed, right? Here's the thought process, and then we need to execute that process. And in order to do that, it definitely isn't realistic that it would be able to be done in a 3-month period. So, you know, I think if the MVP concepts are rolled out in the next legislation and federal rule that's published, I think that the implementation timeframe needs to be potentially 2023 so that you can incorporate it into the certification process, as well as allowing time for, for third-party submitters and others that are necessary in making it happen to implement the process. So those are my comments related to the subgroups. And the only other aspect along the lines with that APM logic is creating a subgroup entity, much like we now have the APM entity for submission, which I think would make it easier from an execution perspective, once the concepts are solidified. So thank you very much for the opportunity to give comments.
Great, thank you, Tricia. All right, we have one more comment from Jennifer McLaughlin. So Jennifer, you are unmuted. You may go ahead.
Great, thank you. This is Jennifer McLaughlin with the American Medical Association again. And I wanted to make two additional comments in response to this discussion. And the first is about the question that Molly raised about, potentially taking off the training wheels. The AMA has certainly been one of the organizations urging CMS to establish a hold harmless policy at the outset of MVP and support bonus points. And we think there is precedent for CMS to do a transition period in MVP similar to the pick your pace initial rollout of MIPS. We think, if there is a certain set transition period for these subgroups to join an MVP, knowing that there is a lower risk of failure and a lower risk of facing the steep 9% potential Medicare penalty, that could incentivize them to participate. We think that's really, really important, particularly at the outset when there's a lot of questions, and particularly to incentivize those who are interested, but who are going to be the very early, pilot testers of MVPs. And then the second comment is that the AMA has made a number of suggestions about how CMS can make MVPs less burdensome and more meaningful to groups who want to participate at the subgroup level, and to anyone else who wants to participate in an MVP. And it really consists of, taking a step back and reimagining MIPS. And there's been conversation already today about how MVPs can be a bridge to APMs. And one of the ways is, considering it and going in and seriously aligning all of the categories so that it is no longer checking the box in each different MIPS performance category, but allowing physicians to report potentially fewer measures and receive credit in multiple categories as MIPS APMs do, because they are in joining MVPs, they're giving up the full choice of all of the measures in MIPS, and they're saying we want to participate and we want to be held accountable for the cost and quality in achieving this one particular patient outcome. I know the AMA has been considering it in conversations with CMS around a prediabetes MVP. So for the sake of this example, those physicians would say to CMS that they are, going to move away from traditional MIPS and opt into MVPs. And by doing that, they should absolutely have a transition period at the outset, and then also be able to report fewer measures and get credit for instance, using PHI that is relevant to prediabetes if they're engaging their patients, using any APIs or other technology that is not CERT, and also if they're reporting on quality and improvement activities that are aligned, CMS could automatically award that credit. And again, a suggestion that we've made to make it a little bit easier when it does come to the data submission for subgroups and for MVPs, a suggestion that we've made, and I'll make again is to customize the data submission portal for subgroups so that if there is a bonus point, those subgroups, when they go in and whomever it is who's submitting the data, third-party intermediary or the practice administrator, physician or other staff, they can see right away they'll get the MVP bonus, and they'll be able to see they won't get a penalty, and they'll see the aligned quality and cost, and they'll see, quality and improvement activities are already aligned, so we'll get, automatically 50% of the improvement activity score. Those are comments. You'll hear them again throughout the session. That's just a preview, and since Burden came up, wanted to share those thoughts. Thank you.
Great, thank you, Jennifer. Okay, next, Jill Sage would like to speak. So Jill, if you'd like to go ahead and unmute your line, the floor is yours.
Yes, thank you. So in terms of aligning or looking at how to incentivize this, and I'll talk a little bit more about this when I comment on some of the MVP design ideas that the American College of Surgeons has been thinking about. And that's looking at how to align patient goals with not just clinicians, but the facilities. I know your team also oversees the hospital measures and the hospital quality incentive programs. And I think especially what we've heard from some of the individuals who have spoken today that are with larger hospitals or larger systems, it's sort of the lift of how do we get this off the ground? How do we how do we think about funding this and implementing it? And I think it's going to be really critical to have buy-in from hospital leadership, especially for clinicians who are employed by the hospital or are relying on the different structures of the hospital. And because this is based on, right now at least based on TIN, that's going to be a decision that's made at probably not the department level. So thinking about how to sort of align the incentives across hospital programs and the MVP program, I think will go a long way in terms of really getting commitment to this program to get it off the ground. So thinking about how to align measures, but then also thinking about how to reward those who would be willing to make a special effort towards programmatic alignment. Thanks.
Great, thank you, Jill. Okay, looks like that's all the feedback we have for the moment. Molly, we will pass it back to you for any more questions you may have.
Okay, thank you again, Lauren, and thank you again for all of our stakeholders who have given the feedback today. I cannot overstate how important your guys' feedback really is here today. So thank you all so much for this. And again, I know those of you who have provided verbal feedback, I anticipate you'll be giving us written feedback as well. And I also know many of you who are not giving us verbal feedback here today will send us over our written feedback. For some of the comments that were made about, so thank you again for the comments on the question I posed of incentives. And for some of the folks who made comments about burden and the bridge to APMs, thank you for flagging those. I'm not going to dig into those quite yet because we will be talking about those in more detail in our session 2, which we will be handling in the afternoon. But thank you for flagging those, and I'll just say to folks that we will be talking about that in much more detail today. There was one other question, though, that I heard someone ask that I did want to give a bit more follow-up to, and then just see if there's any other feedback there. And then I think we can probably adjourn the session. I know I've said that maybe once or twice already, so I apologize if I have to say it again. The feedback that you guys are giving us is really helpful, and we don't want to cut the session short because, again, there's only certain times we can have this really robust discussion with you all. But so the comment I did want to follow up in a bit more detail on, so it was a comment about in the concept of when we have subgroups and the forming of the subgroups, whether or not there would need to be thresholds that would need to be met to actually move a given subgroup into an MVP. I just wanted to provide a little bit more clarity at this time on our thinking. So at this time, we are anticipating that given voluntary subgroup reporting, that subgroups could self-select who would be part of their subgroup, the MVP specifically that they would be reporting on, and we do not anticipate that there would need to be a threshold, at least for the initial years. Again, this is part of, in our thinking, a way that we can really try to provide as much flexibility to the group organization to self-identify within their organization, okay, this subset of my group, I want to have them focus on this subgroup MVP area. And so then again, that subgroup could completely be self-identified based off of the group. But again, so that's what we are initially thinking for the first few years. With that being said, though, interested in folks' feedback on whether or not they agree with that approach. And if folks do, we also would be interested in understanding if at a later point in time, do folks have any feedback about establishing a threshold for subgroup formation? Do folks feel that this is something that we should consider, or is this something that folks are not really interested in at this juncture? So let me stop there to see if folks have any other feedback they'd like to provide on this question. So I will go back on mute. Thank you.
Great, thanks, Molly. All right, we will give it a few more minutes for feedback to come in. Again, just raise the green hand icon on your go-to menu to show your interest. As a reminder, we will not be looking at feedback sent over the chat box currently, although it will be reviewed after the session. Okay, so we'll give it a few minutes for interest to come in. In the meantime, we do encourage everyone to also submit written comments on the topics being discussed today to the CMS MVP feedback@ketchum.com inbox. Please do this by 11:59 p.m. Eastern Time on Thursday, January 14th. And again, to show your interest to provide feedback over the phone, go ahead and just raise that hand icon on your go-to menu and we will call on you. We'll give it a few more minutes. Okay, Trudy Fierce, if you'd like to go ahead, you are unmuted.
I may have missed what the most recent question that you're asking about. It kind of got blurred for me, but feedback relative to, the submission mode and methodology, if they're not done via ECQMs or something equivalent, then, because the objective is to go to the digital form, you will need the CERT requirement for your EHR in order to do that. But just because an EHR has got a CERT requirement is really not the nth. You're not all the way there to the finish line. They are just providing you a framework. You still have to build out the measures yourself by institution based on how you, your institution chooses to implement that EHR software. So there's a lot of work that has to occur beyond that. So again, keep in mind that the cadence of when the EHRs release their yearly or annual or quarterly, bi-yearly, whatever their update cadence is, that's relevant to the ECQM framework that they're providing and that they're certified on. So keep that in mind. And if you're going other submission methodologies like qualified registries, then that's another animal that eventually should be part of your EHR. Ideally, if you want consistent reporting again, but food for thought is you got to keep in mind that there's a heavy lift by the EHR vendor, and then there's a heavy lift per institution or per and per MBP.
Okay, great. Thank you, Trudy. Okay, we'll give it a few more minutes for interest to come in, and we will call on you when you raise your hand. Okay. Oh, sorry. Hands on away. Molly, in the meantime, if you'd like to comment or ask any more questions, we will pass it back to you.
Okay, thanks, Lauren. That was the last question that I had based off of the discussion here today. Again, some of our commenters touched on items that we will be discussing in our afternoon session. So there's a lot of great feedback more to come. So let me just re-ask the question I posed again, because I think we have one commenter who wants to provide feedback on that, but I'll just ask it here again. And if folks aren't ready to provide feedback today, if you could just think about this and respond to this in your written remarks. So again, the question is, when we think about subgroups being formed, again, our thinking is that at least for the initial years, it would be voluntary and there would be flexibility provided to the group, the organization, on how they self-identify the subgroup and who is part of the subgroup, as well as what MVP they would report upon. With that being said, though, we can see a benefit of having some sort of threshold put in place for the future, that if you are a multi-specialty organization and if you have a significant number of cardiologists, for example, you would need a report on an MVP that is cardiology focused. So we could see a benefit to that in the future, again, as we have a more robust set of MVPs and as subgroup reporting further expands. So interested in any thoughts or feedback that folks have on that concept, both our initial approach and then the concept that at some point in the future we may implement that. So let me stop there because, again, I believe we do just have someone else on the line who's ready to give feedback verbally here today. If you are not ready to give feedback on that question today, again, if you can think about it and just provide it to us as part of your written remarks. So Lauren, I'll turn it back to you.
Great, thanks, Molly. All right, Leopoldo Rodriguez will go ahead and unmute your line. Oh, looks like you need to be connected to audio. So in the meantime, we will call on Sharon Hibbe. Sharon, we've unmuted your line. If you'd like to also unmute on your end, you can go ahead and provide your feedback.
Yes, thank you. This is Sharon Hibbe, and I'm from Advanced Health Outcomes. First of all, as many people have said, thank you for the opportunity to provide comment on an abundance of discussion topics today. So that's very helpful. You know, as I'm listening to a lot of the different speakers, a lot of the commenters, there seems to be positives and negatives to the subgroup reporting in related to the subgroups. Some speaking to the positive or negative performance that subgroups might incur, and so possibly as an opportunity for individual subgroups as well as overall group performance, and provide very clearly some sort of temporary bonus points. Maybe I know you talked about you don't want to over bonus people, you don't want to water down for performance, as an opportunity to learn. So you know, this is learning in action, where you're building the boat while you're trying to launch it. So we are looking to understand the impact of subgroups and trying to also get to things that are more meaningful to subgroups so that they can improve their performance as well. So, you know, maybe at the end of the year, allow providers to assess their performance. CMS assesses their performance and certainly provides value to, you know, to the providers, the groups, and the subgroups, and the overall groups that is most beneficial, the highest performance rate. I think numbers of commenters have discussed precedents already been set and bonus point structure clearly has already been developed. So maybe on a temporary basis as a mechanism to learn. Molly, you've heard loud and clear, and CMS has published voluntary participation all over the place for the MVP, but maybe this is another level of voluntary participation for people. As an opportunity, someone also spoke to, please test this before we implement it nationally. Maybe this is an opportunity to provide a sub-step to do some testing and such. So it really sounds like we need a little bit more information. You know, is there structures that are unintended that will be beneficial or of negative and unintended consequences to either the whole group or to the subgroup by just implementing it without some sort of testing. So, and similar to everyone else, thank you for the opportunity to provide comments.
Great, thank you, Sharon. Okay, it looks like that's all we have for feedback for now. So Molly, we will pass it back to you to wrap up session 1.
Okay, thank you again to everyone who has provided your extremely valuable feedback on this first session here today. Again, myself as well as a number of others have been jotting down all of what folks have been saying, but I do know that the vast majority of you will also be submitting your feedback to us in writing, which again is due a week after today. So I just want to say thank you again for your feedback for the first session this morning. So Lauren, I will turn it back to you to tee us up for the break and our next session. Thank you.
Great, thank you, Molly. That concludes session 1 on MVP subgroup reporting. Please note that session 2 on MVP design and overview will begin at 1:00 p.m. Eastern Time. If you'd like to remain connected to this webinar platform during your break, please do so, but please ensure that your line remains muted, whether you're connected via your phone or via computer audio. We will stay silent until the next session begins. Again, we will send an announcement close to 1:00 to let you know when the next session will begin shortly. Thank you.
All right, well, good afternoon, everyone. Welcome back to the folks who are with us this morning, and welcome to some new folks we might have this afternoon. We really appreciate you all. This discussion this morning was great, and we're really looking forward to a couple great discussions on our afternoon topics. Before we get started, I just wanted to give a few quick reminders. And again, this is Katie Moore from CMS. And so the first one was Dr. Schreiber this morning touched on our extreme and uncontrollable circumstances application deadline extension. So just wanted to remind folks that we have extended that application for COVID-19 related applications to provide that flexibility for clinicians that need that extra support. So just wanted to make sure everyone was aware that that deadline was extended to February 1st. And we do have on our QPP website in the resource library, we have a great video and how to submit an application guide and everything you could need to know about the application. So that is available. As we discussed earlier this morning, we touched on very briefly background of MVPs, but want to focus today's sessions on some future potential policies. So wanted to highlight that we did do a deeper dive MVP overview webinar a few weeks ago, and we have that information on our QPP webinar library. So we have the recording, transcript, slides, all of that is available, as well as some other resources on our resource library. And we also have updated our MVP webpage when you go to qpp.cms.gov. And there is now a new page that is specific to MVP candidate submission. So it has all of the information about our finalized policies in 2021, including our MVP template. So I encourage everybody to check out that for more information on background. And then As we mentioned earlier today, we're going through information that we provided, questions that we put out to the public in our MVP Town Hall Prep Guide. So we're going to go through them on these slides today, but if you want to look at them in hard copy in more detail, that is available at the top of our QPP resource library. It's the very first item under the Regulatory Resources tab. And then last reminder is that don't worry if you missed out on this morning session, or if you can only stay for session 2 and can't stay with us for session 3. Our entire day's event will be is being recorded, and our slides, recording, transcript will all be available in the next couple of weeks on our QPP webinar library. And again, in that prep guide are more details on how to submit written comment. We are accepting formal written comment on the questions we've posed today and in the guide through the 14th, so next Thursday. All right, that's enough of me talking about reminders. I would like to hand it over, and I'm very excited you were able to join us this afternoon. We have Dr. Lee Fleischer. He is CMS Chief Medical Officer and Director of the Center for Clinical Standards and Quality. So thanks so much for joining, Lee, and I will turn it over to you.
Thanks so much. It's really a pleasure, and I assume you can hear me?
Yeah,
correct?
You sound great.
Great. Thanks so much. It's really a pleasure to be here, and I'm sorry I could not join earlier or later, but I will get a full briefing on the highlights of the day and what's so important. I joined CCSQ and CMS 6 months ago, a little over 180 days ago, coming as a anesthesiologist and chair of anesthesia at Penn, and still practicing anesthesia a couple times a month. So I remain a frontline clinician in a hospital setting, so I understand a lot of what you do, and in fact have been involved in the quality ecosystem for years, having been on the original technical expert panel that helped create the skip measures, for those of you who remember that. You know, the MVP program, which I'm really proud of, having come to CMS and the Quimby group who really oversees it, and Michelle Schreiber with her vision for how do we get measures that really align with what patients care about, that really align with the delivery of care at the more specialty-oriented setting rather than overarching. You know, as I think about it as an anesthesiologist, does quality of whether or not my primary care physician, since it's the same tax ID number, really mean anything about whether or not my department previously or myself gave good? And having been the chair of the Consensus Standard Approval Committee over at NQF and treasurer of the board until I took this position, you know, this idea of joint accountability and how can we create MVPs that really cover sort of the multiple groups of care and aligning with that care that patients care so much about is really important. So I'm excited that this group is so engaged. I'm excited that you're thinking about where to come from here. Sorry, the new Zoom world in which I'm getting visited by my daughter's stepdog. And sorry about that. And just I'll be part of those highs and lows of the week. And most importantly, that we think about how do we improve the ecosystem for the patients that we serve. So I look forward to where you're going next, and thank you for being so engaged today. And with that, I'll turn it back to the team.
Great. Thanks so much, Lee. We're glad you could be with us. I'm going to turn it over to Sophia Sukumar to get us started on our afternoon session with session 2 and more details on our MVP overview.
Great, thanks Katie, and hi everyone. Welcome back to our afternoon session. If we can move to the next slide, please. Okay, just to set up how the conversation will go today for the next session, As Molly had previously done in session 1, in session 2, we're going to cover several topics here. And what we'll do is really set up the content and the background for you all, and then kind of set up the questions as well, present to you and remind you of those questions I believe that were included in the guide, participation guide. And then at that point, we will have our lines open for those organizations that have indicated they want to provide feedback ahead of time. And those folks can go ahead and present. And then if time permits, we will open up our lines to see for any other stakeholder that weren't necessarily, had reserved time to provide feedback. If we have time, we will allow some time for that before we move into our break and then following our session 3. So within this session, we're going to cover 5 topics. And we do know it's a lot, so we're happy to go back and forth as the feedback session opens within each session. So session 2 feedback will cover these 5 topics, and feel free to have pen and paper on hand as we go through the notes, just to make sure you're capturing and flagging down any questions you might want to ask us. So in session 2, we're going to cover the value of MVPs to patients, the MVP alignment with APMs, which is a question we hear a lot about, MVP participation, that is the clinicians who will have MVPs available to them and what those reporting requirements may look like, clinicians' choice of MVPs, as previously described in previous rules. We did indicate that there would be some choice with not making MVP reporting mandatory at this time. And also the mechanics of how clinicians would participate within a given MVP, what that would look like, what we're envisioning. So let's move to the next slide, please. Slide 19. So to here, we'll start and we'll focus in on the value of MVPs to patients. So previously, as we set up the framework for MVPs, we did emphasize that we want MVPs to be more meaningful for clinicians in terms of the way they report on more meaningful measures and activities that are really related to their clinical care practices. We also want to make sure that the MVPs are valuable in a sense to patients as well. We want to make sure the information that's gathered within the MVP and is measured within the MVP is valuable to patients so that they can make informed decisions about their provider choices. And to that point, within the 2021 rule, we did make some updates to our MVP guiding principles, and we did include a third guiding principle to say that wherever possible, the patient voice must be included. And when we say wherever possible, we mean through the MVP development process, where collaborators outside of CMS are working to kind of come up with these MVP concepts, that they include patients as a part of that development process to really get their insight and make sure that, yes, it's understandable from the clinical perspective, but also from the patient perspective, what you're trying to measure makes sense to them. But then also within the MVP itself, having measures or activities or a mix of both that really represent patients, whether that be patient-reported outcome measures, patient experience measures, patient safety measures, the list goes on. So really making sure that we have representations as many ways as possible is our preference, and that's something we wanted to emphasize with the updates to the guiding principle. In addition to that, we also updated the second guiding principle to highlight the importance of more comprehensive multi-specialty reporting from subgroups as a step in improving comparative performance data. And this really, as we discussed in the first session with subgroup reporting, it comes from, stakeholders previously mentioning that group reporting doesn't necessarily reflect everyone in the group. And, having the ability to have subgroups could possibly lead for more meaningful measurements in that manner. So again, we updated the second guiding principle to reflect that. That also would also add additional value to patients by providing them with more meaningful data on a given clinician. The third item relates to stakeholders that are developing MVPs, as I mentioned before, should include those patients as a part of the development process. So as an example, in our rule, we did mention you could possibly include patient representatives as a part of your development process, your technical expert panels or committees that review or meet to kind of pull together MVP candidate before it's submitted to CMS.
We'll really look for you all to, take innovation and keep that in mind as you come up with ideas of how you can include patients. We're not being prescriptive on there's only one way to do this. And we're not saying there's a right way or a wrong way. It's more of we want you to take a proactive manner in terms of including patients as a part of the development process. And we want you to tell us how you did that as a part of your MVP candidate submission. It's not that, again, there's a wrong way or a right way, or you're being evaluated on that in some manner or form. It's more of trying to be as comprehensive with the patient inclusion and patient voice as much as we can. We're also considering ways to expand the inclusion of the patient voice beyond the existing CAP survey measure and also the existing patient-reported outcome measures we have in MIPS. And to that point, as we work to continuously expand our patient-reported outcome inventory within MIPS, we've also considered that patients can be represented through patient experience and patient surveys and also patient safety measures as well. So we understand there are some limitations with our given inventory, and that might change in the future, but for the time being, we can expand our thoughts in terms of how we think of patients to really include measures that reflect other areas, including so that we can make sure that the patient is represented even with our first few sets of MVPs that come forth within the next year. Next slide, please. The next item we wanted to touch upon is related to the MVP alignment with APMs. And we've heard a lot of questions based off of our finalized framework, but also our 2021 rule from stakeholders on what do we mean by aligning with APMs? What does that mean? And it can be taken in several different ways, which is why we wanted to cover here. So there are some APMs that exist, and there is a way where we can possibly have MVPs that include measures from related existing APMs. But we don't want to say that we're limited to just that. We want to say that MVPs can exist, and they can support an existing APM and have a corresponding APM, but they don't have to. The point of the matter is that MVPs in general should just generally support the shift to value, and I think that's something we have in common with the APMs, that we would want to support that shift to value. So generally, we'll get to a point where we have MVPs that have some overlap with existing APMs, maybe it's similar measures, but not all our MVPs will, and that's okay. We also don't want to set the precedence that just because an MVP is in our program and there's no existing APM, that there will eventually be an existing APM that will correspond to that. That's not necessarily a realistic expectation we want to set. There are various timelines that we have to consider and constraints within the MIPS program and innovation that is intrinsic to the APM and model development process. So we want to be mindful of that and not set those expectations. We do anticipate that MVPs may move clinicians along the value continuum by leveraging APM measures where feasible. And we do feel that that familiarity with the measures may allow clinicians to feel more comfortable with that gradual glide path to an APM if they feel that that's the right path for them. We also believe that linking cost and quality measures, that the MVP experience with cost and quality measurement may help to improve clinician readiness and to take on financial risks within the APM. We don't want to set the precedence that every MVP here will become an APM. We want to be clear that APM development will not be dictated by MVP development. They are two separate processes, but in an instance where we can include a measure that's in the APM within the MVP, that is something we would want to consider as a part of the development process. The fourth guiding principle within the MVP guiding principle states that MVPs will reduce barriers to APM participation by including measures that are a part of an APM where feasible and by linking cost and quality measurement. What we would like to hear from you all is on what you believe is the best way forward to move for MVPs to remove barriers to APM participation. Other than the familiarity of utilizing some of the similar measures where there's a bit of overlap that will help, allow clinicians to get used to those reporting those measures? Are there other things we should consider when we think about removing barriers from APM participation? Overall, our larger goal is to accelerate the percentage of healthcare payments that are tied to quality and value. And but we do recognize that clinicians do practice in various ways, and that not all clinicians have a clinically appropriate advanced APM available to them. So those are all factors we do want to keep in mind, but we really look for you all to provide input, and we will get to the questions that correspond to this topic soon. Let's move to the next slide, please. All right, and in this section, we're going to focus a bit on MVP participation. As mentioned in the request for information on MVPs through the 2020 rule, we did note that as technically feasible, we would establish a methodology that would allow us to identify and assign in advance of reporting the relevant MVPs for a given clinician or group, and require the clinicians or group to report on those MVPs. And we did mention that we would consider self-assignment, which is, allowing the clinicians to choose which MVP they would report as an alternative. We did ask how we would identify which MVPs are most appropriate for a clinician if we did take on the first option of assigning. And we did receive a lot of feedback on this policy concept that we had put in the RFI, and a lot of stakeholders did not support the assignment option and felt that MVP should be optional. So that is something we are aware of and are tracking to, and our thinking has evolved in terms of the way we think about MVP participation. We initially said that MVPs would be mandatory and that we would assign MVPs to clinicians, and we heard obviously that clinicians don't want to be assigned or be told exactly what to report. They want to have some choice. So in the 2021 PFS rule, we did finalize that MVPs will be optional, and that we would also continue to maintain, for the time being, the current MIPS participation options, the traditional MIPS reporting options across the 4 performance categories. In response to the stakeholder feedback, the large amount of feedback we've received with regards to making MVPs voluntary, we at this time are not considering or thinking of assigning MVPs to a clinician by their clinician specialty type. Instead, we were opting to provide guidance around the types of practices, and depending on the types of practices and clinician types and groups, as to what type of MVPs are available to them to select from. This might mean that they have a few to choose from, and then they would take it upon themselves to decide which MVP they would want to report on if they choose to report on an MVP in lieu of traditional MIPS. Next slide, please. And to build upon MVP participation, a part of that would be also the mechanics of participation. And so we do anticipate that those clinicians or groups that are actually interested in reporting through an MVP in lieu of traditional MIPS will need to identify their intent to report on a specific MVP. And clinicians and groups that intend to participate in the MVP will need to notify CMS of their intent to report of a given MVP, either at the time of submission or during the performance period on July 1st, which is about the same as the registration deadline for CAPS for MIPS. So if we do go with an intent to identify that you're reporting an MVP at the time of submission, that might look like something more of a technical identifier that will indicate that you're uniquely selecting an MVP over the traditional MIPS, and that will help us determine which pathway in terms of scoring and which rules would apply. We recognize that there are MVPs available. There may be MVPs with available measures and activities that are not applicable to a clinician's scope of practice. So in those instances, we would not expect a clinician or a group to report an MVP. For the time being, as the MVPs are voluntary, I think our expectation would be that if a clinician reviews a given MVP and finds that there are no applicable MVPs to them, that they would choose to opt to report through to their traditional MIPS, which they would have more choices in terms of expanded inventory of measures and activities for the time being. So our intent here is that if you choose to report an MVP, you're doing so because you've reviewed the MVP and found that there are relevant measures and activities that are applicable to you, and you are able to report data on those measures and activities. So with the choice there and it being voluntary, that is the expectation we are tracking to. And that's what we are thinking would be the path forward for now. Next slide, please. Okay, and with this slide, I'm going to turn it over to Molly McCarris to take over with the questions for session 2. Thank you.
Okay, thank you, Sophia, and thanks again, everyone, for coming back for our afternoon session. Really hope we have as much, if not more, great feedback that we heard from you all in the AM session. So I'll go ahead and read out the questions, and then similarly to what we did with our initial session, we'll open it up for those folks who indicated to us that they would want to provide comments for our session 2, and then similar to how we handled our initial session, we'll then open it up for other commenters with time allowing. So since Sophia touched on a number of topics within this session, just try to think back to, this was the initial topic Sophia was touching on, which is ways to amplify the patient voice within the MIPS value pathways, which you've heard Sophia talk about today, as well as when we had our MVP development webinar back in December. And of course, you all heard both Michelle and Lee touch on that earlier today as well. So as we think about amplifying the patient voice within MVPs, the questions that we have for all of you are, what additional steps should we, CMS, consider in making MVPs more impactful to patients and to better integrate the voice of patients? Also within the context of MVPs, how should we define the inclusion of patient voice for non-patient facing clinicians? We do have a specific definition of who's considered to be non-patient facing under MIPS. So very much interested in thoughts and feedback from those groups on this issue today. And then also, are there other types of patient-focused measures that we should look to include within our MIPS value pathways? And really anything else related to incorporation of the patient or amplifying the patient voice that you all think we should consider as we work to move MVPs and the quality payment program forward. So let's go ahead and move on to the next slide, where I will go over our questions for our alignment grouping concept with APMs. So again, as Sophia has gone over, we believe that a grouping concept, such as categorizing MVPs based on whether or not there's a corresponding APM or not, can help us clearly articulate how MVPs can help reduce barriers to APMs. So, and again, as you may recall, when Sophia was talking about the grouping concept, we believe that the grouping concept could consist of MVPs that have a related existing APM, and then also, MVPs that have a related existing APM, and then secondly, MVPs that do not have a related existing APM. Again, please recall, as Sophia noted, that while we are looking into the grouping of MVPs in relation to APMs, we do not believe it's a realistic expectation to set that MVPs would transform into an APM. And again, this is due to the various timelines of our APM models, MIPS timelines and constraints of APMs, and again, the innovation that is intrinsic to APM model development. So again, for our questions here, how could this grouping concept be utilized to help facilitate movement to APMs? And how could the grouping concept be helpful to stakeholders who are developing MVPs? And then lastly, what other criteria should we consider as part of these groupings? For example, should we categorize MVPs based on if they are procedure-based or episode-based MVPs compared to population-based MVPs? Again, when you think about the way that certain APMs are structured, oftentimes they could be based off of either a population of care or an episode-based of care. And then the last question on this slide is, should we, CMS, prioritize development of MVPs in areas where an APM exists or in areas where APMs do not exist to fill in the gaps. So again, thinking about that grouping concept. Also, I'll flag in case, as always, and with everything we're talking about here today, if there are other concepts or grouping considerations that we should be thinking about as we look to move clinicians forward into MVPs and reduce barriers to APMs, we'd of course love to hear about that. So let's go ahead and move on to the next slide, please, with just a few other questions on this topic. So again, I guess it was just last year's rule, the CY, or no, I think it was the year prior to that, the CY 2020 physician fee schedule proposed rule. Time is flying nowadays. We solicited feedback on ways that we could reduce barrier to APM participation, and we generally heard that barriers could be reduced by providing more robust performance feedback, increase APM availability, streamline reporting by MVPs to MIPS, increase risk experience, and offer risk education. So having that in mind, what elements of APM design might we consider in developing MVPs, such as should we have similar quality measures, similar activities, similar cost measures that would make clinicians feel more confident in making the decision to continue moving towards value in an APM? We do hear from stakeholders that there are concerns on making the leap from MIPS to an APM. So understanding that in more detail would be helpful. Also, are there any additional tools that we, CMS, could provide to help clinicians further prepare to take on more risks as they prepare to move to an APM? And then is there anything else more that we, CMS, could provide to help with this, such as access to more data, again, or anything else you all may be thinking of? Additionally, what, if any, are the scenarios where similar APM and MVP topics should utilize different measures? So again, as we think about our grouping concept, this is kind of outside of that. So for example, if we have a cancer care MVP, should that cancer care MVP have similar measures to the oncology care model, the OCM model? Or would practices performing on these measures in MIPS make practices feel more confident about joining an APM with similar measures in the future? So should we have similarity or should we not have similarity? And any feedback or thoughts that you all have on how that can further prepare stakeholders to take on more risk. And then the last question that we have as we think about our alignment with APMs is how can we ensure that MVPs are meaningful to specialty clinicians that have limited applicable APM models available to them? So again, we do understand and acknowledge that there are not currently APMs available to all clinician specialties or even all areas of the country where clinicians practice medicine. So any further thoughts that you all have on how we can, as we simultaneously work to build out MVPs, the agency, we are also simultaneously working on developing new models. How can we ensure that MVPs are still meaningful while those actions still occur? Okay, let's move on to the next slide, where there's a couple questions we want to go over related to MVP participation. So as we've touched on here today, and you've heard myself and others talk about this in prior sessions when we think about MVPs, we have indicated that we do at some point in the future plan to retire what we have been calling our traditional MIPS program. That's what we're calling the normal way that folks participate as compared to our new approach for participation, which of course is our MVPs. So again, we have said that we do anticipate at some point in the future, our traditional MIPS would discontinue and we would just have MVPs. I do want to be clear, we have not yet said when that would occur because, again, we fully recognize that a robust set of MVPs we need to be available before we can get there. But so a couple questions that we have as we think about that, also taking into consideration, of course, the COVID-19 public health emergency pandemic that has impacted all of us and has changed the way that we live our lives and really do everything. So we understand that that could have impacted the different stages of readiness to move to MVP reporting. So the questions we have for you all here are, how has the pandemic, the PHE, impacted clinicians' ability to move along the continuum of value increasing the quality of care provided while taking on greater financial risk. Has the pandemic sped up any movement towards taking on more financial risk and moving into an APM, or is the sense that it has delayed this movement? And anything else that we, CMS, should be thinking about for the industry as we look to move some of these items forward. Also, as we think about the future, what criteria should be met before traditional MIPS is retired? So again, I've talked about that we want to ensure we have a robust inventory of MVPs available, but any other considerations that we should have as we look to the future on when that should occur. And then again, should there be a certain threshold of MVPs which are available and applicable for eligible clinicians to report before traditional MIPS is retired? And okay, let's go ahead and move on to the next slide. I think there's just a couple more before we'll pause for questions, or sorry, for your guys' feedback on all of these questions. Okay, thank you. So the next item is our clinician choice of MVPs. So again, as Sophia has gone over as part of our background here, our thinking has changed on the role of clinician choice within MVPs from when we initially solicited feedback on MVPs to where we are now. But so our questions are, since we do anticipate that reporting MVPs will be voluntary, how would you all suggest that we encourage participation in MVPs over traditional MIPS reporting? So I know at the earlier session, we touched on some incentives specific to subgroups. Interested in hearing on, was there anything that was touched on in the earlier session that folks feel would be applicable here? Or are there other methods that we could use to really encourage that participation? Additionally, how can we, CMS, help clinicians, groups, and third-party intermediaries overcome barriers to be able to report an MVP? Again, is there anything more we can do to help with the readiness? Lastly, clinicians and groups have expressed concern about the operational burden associated with transitioning to MVPs from MIPS. We've also heard some of that today, particularly in the subgroup context. So how can we, as CMS, further minimize these operational challenges as we implement MVPs? And let's go ahead and move on to the next slide, which is our last set of questions. Still focusing on clinician choice. So if MVPs, so working under the assumption that MVPs are optional, how do we make sure that clinicians are choosing the appropriate MVPs to report? So again, thinking back to, as I was just touching on how our thinking has changed here, we did initially think that we would want to assign clinicians to an MVP, but we heard really loud and clear feedback from all of you that that would not be appropriate. We do still have the concern, though, that there would be clinicians and certain stakeholders who would choose an MVP that may not be the most meaningful or most applicable to them, but it may be an MVP that they feel they can score well on. So maybe there's, a measure that would apply to them that they feel they can do well on, but the rest really wouldn't. That's not really the intent of MVP, so we want to work through ways that we can address that. So again, for example, should we, CMS, assume that a clinician, when electing an MVP, would be able to report on all the measures and activities within a given MVP, a minimum number of measures or activities, or at least one measure or activity from each of the quality, cost, and improvement activities performance categories? Again, we're setting promoting interoperability to the side for now, since we have indicated that we anticipate that will be part of the foundational layer, which would be required for all MIPS eligible clinicians, similarly to how it is required today. And so along with that, what kind of information could we, CMS, provide to help facilitate the choice that clinicians make of selecting an MVP? And with that, I believe that is our last question. So let me go ahead and turn it back over to Lauren so we can begin our feedback session. Lauren?
Great, thanks, Molly. All right, so as stated, we now have time for our scheduled feedback session. As time allows, we may be able to open it for an open feedback portion towards the end of the session. But please remember that we do have 3 different feedback portions today, and this one focuses on MVP design. So we ask participants to stay on that topic and keep to 5 minutes to ensure that all those who wish to speak will have the opportunity. So first we have Laura Vera. Laura is speaking from the American Academy of Dermatology. And Laura, we are unmuting your line, so you may go ahead and provide your feedback as soon as you unmute as well. Laura Vera, if you'd like to unmute your line, you can provide your feedback. Okay, we will come back to Laura. In the meantime, we have Jill Stage, who's speaking from the American College of Surgeons. So Jill will unmute your line. And if you'd like to unmute as well, you may go ahead.
Okay, thank you. So in thinking about the design for MIPS, the College of Surgeons really wants to, and has been in discussions with CMS to really rethink the strategic direction of MVPs so that they can really be a true pathway to patient-centered value. You know, right now in MIPS, there's no coordination of the care team around the patient. Measures aren't reflected of care in surgery. The programs are really measuring erratic components individually, such as the surgeon separate from the anesthesiologist, the radiologist, the pathologist, and so on. And, you know, I think the reason why I bring that up, again, I mentioned this earlier in the morning during the subgroup discussion, is because I think that in those subgroup discussions, it's really going to be important to think about the subgroup within care centered around the patient versus, okay, can my specialty report this? So I think that's just really something that's important to continue to focus on, because really, until we kind of can focus on the patient, we're just going to be pitting members of the care team against each other if it's not focused on the team itself. You know, and the result of this has really been that, at least in surgery, the current framework, which I think is still present in MVPs, is really failing to drive improvements in surgical care, just because it's really disconnected from the healthcare delivery process. And so I also want to say, and it's great that there's this a lot of attention on patient voice, but I would also urge a focus on not really, I find voice is maybe vague, but thinking about patient goals of care and what does that look like and how does that change sort of how the care team can come together and coordinate around the patient. You know, as I mentioned, I think that the MVP program, as it's regulated, it still needs to come a long way. I think we're still looking at what we have, like what APMs we currently have and what MIPS measures we currently have. And just kind of doing that backwards, I'm not sure if we're really going to get to the goal of defining value for patients in the MVP program. So, and this is the college has been working with CMS on a surgical MVP, but what we really think will be the way to do this is to really focus on first the quality as a program, instead of looking across the 4 MIPS quality or the MVP buckets and the MIPS measures and so on in silos, but building the program first and then thinking about, okay, how is that program then going to be incentivized in a payment program? And so, you know, I think the college has been doing this work for a long time. For decades, we've had quality programs, such as the trauma verification program, bariatric accreditation, Commission on Cancer, more recently, geriatric surgery verification, to name a few. And those are all quality programs. They use program standards with the facility and the providers, and they align for continuous, reliable, and standardized care. And part of that is not just that the patient outcomes align with the goals, but how do we get to those goals? We need in the work that we do, we know that we need adhering to clinical protocols is important. Having the correct personnel and equipment, having an institutional commitment from the administration is critical. So all of those things make up the program that then can deliver that patient-centered, condition-specific goal of care, which would be defining patient value. So I think we have some guiding principles that I'll just go through very quick. The one is this should really be spanning across surgical care to verify structure, process, and outcomes together. And that would be reflective of the comprehensive patient journey and the patient goals. Linking clinicians and facilities to achieve goals is critical. Shared accountability is going to be critical for moving to APMs. Reflecting programmatic alignment across those structures and processes and outcomes. And then looking at those structures and processes for performing quality improvement across the team. Incentivizing physicians and hospitals and how they can rely on interrelated quality measures. So there's one quality target for the surgical team. It's not separated by the hospital payment schedule, the physician payment schedule, and then other payment quality targets from other payers that they're also trying to meet and check the box. And then think about rewarding and incentivizing this and looking at how programmatic alignment can be achieved. And we think that in doing all this, this will really define value from the patient's perspective. It'll build the team and the infrastructure needed, and it aligns the facility and the teams for value. And I think that I saw a really good example on the MUC list that was recently out for comment, and that was the hip and knee patient-reported outcomes. So instead of focusing on SSI, reoperation, or readmission, things that patients don't think about when they go to, for example, the surgeon to fix their hip, thinking about shared decision-making, thinking about how functional goals can be achieved, and then again, thinking about all the programmatic resources that are needed to actually achieve those goals. And so in saying that, I think that we definitely believe in this necessary step towards value-based care is first building a well-structured, verified surgical program. And then with the right framework, I think surgical teams will define surgical care fit for quality measurement and improvement. And then patients and insurers will be able to better assess surgical value. And I'd like to thank the CMS team because they've been working really closely with us in sort of being creative and figuring out how this type of strategic direction can be supported. And I look forward to work and sort of the discussion that might come out of thinking about quality from a programmatic perspective. Thanks.
Great, thank you, Jill. Okay, next we have Jennifer McLaughlin from the American Medical Association. So Jennifer, we are about to unmute your line and you may go ahead and provide your feedback.
Great, thank you very much. This is Jennifer McLaughlin with the American Medical Association. Thank you again for hosting this MVP Town Hall CMS, and thank you for the opportunity to provide comments on MVP design. And thinking to one of Molly's questions as she kicked off the participant feedback section of this session about the applicability of some of the incentives that were recommended during the subgroup session this morning, I just wanted to reemphasize that we do think those types of incentives are just as important for everyone who's participating in an MVP, whether as a subgroup or individually or as part of a group. Again, I think it's really important that there's a glide path for early adopters to reduce the burden. And also this point that I'll pick up from Jill's comments about focusing on making MVPs a more holistic approach to participation rather than focusing on 4 different categories within MIPS, and instead allowing physicians and clinicians to spend their time and their resources working towards a singular patient outcome or episode of care. And I wanted to turn next to the questions about the value of MVPs to patients. And AMA is concerned about CMS's continued emphasis that MVPs include population health administrative claims measures as a foundation to MVPs. The population health measures move the MVP concepts away from incorporating the patient's voice, measuring clinical conditions and outcomes, and generating real-time feedback. I think assessing physicians on broad measures that do not differentiate care among specialties does not lead to improved patient care or, for purposes of public reporting, to providing useful information of care. For example, measuring all physicians on all-cause readmission and comparing an orthopedic surgeon to a primary care physician on the same measure does not provide a patient any meaningful information or assist the patient in determining the most appropriate physician to treat them for a particular condition. We recommend that CMS thinks about quality as a program and not about the MIPS categories in silos. The next set of questions we wanted to address are about MVP alignment with APMs, and the AMA urges CMS to develop MVPs to serve as both a long-running performance-based option within MIPS to improve physicians' and clinicians' experience, and also as a stepping stone for clinicians who are moving from participation in separate, unrelated MIPS measures to participation in an APM. Maintaining the MVP as a long-running option in MIPS will be especially important for small practices that face more challenges in MIPS and have lower mean and median MIPS scores than rural and large practices. However, they may not have a sufficient number of patients or financial capital to invest and participate in an advanced APM. The AMA recommends several steps that CMS can take to reduce barriers between MIPS and APMs. For example, CMS should consider MVP proposals that include more flexibility to improve value for the patient population. For example, a specialty society proposing that management of a condition be eligible as an MVP could propose certain payment changes to support improvements needed to care for this condition, such as paying for collaborative care to help support team-based approaches to managing patient care. Although MVP clinicians would not be subject to the two-sided risk requirements of advanced APMs, the MIPS measures of cost and quality for the episode and MIPS payment adjustments will serve to hold them accountable in a similar manner to APM participants. CMS should also provide claims and QPP data to the participating practices. This is something that this is something. I'm so sorry, I have an echo now.
Sorry, Jennifer, we'll get that sorted.
Okay, apologies. This is the second recommendation I wanted to highlight. Okay, great. I should no longer have an echo. Is that a really important advantage of participating in APMs is that CMS provides claims and in certain instances, and in this instance, we think it would be important, QPP data to participating practices. And so we also recommend that CMS provide the same level of feedback to MVP participants. And then lastly, we wanted to, as it relates to this conversation, reiterate our concerns with CMS's decision to eliminate the MIPS APM scoring standard and transition all MIPS APM quality measures to the APP measure set. The one-size-fits-all approach does not take into consideration the spectrum and variability between the MIPS APM programs or create a set of measures that better inform patients. Lastly, I wanted to wrap up by talking about MVP participation and the questions that CMS has raised, and state at the outset that AMA does not support retiring traditional MIPS. In a sign-on letter to CMS sent in April of last year, the AMA joined 37 national medical specialty societies in strongly urging CMS to make MVP participation voluntary and to incentivize physicians to opt into an applicable MVP if there is one available. We do agree with CMS that the COVID-19 public health emergency is severely taxing physicians and causing significant financial distress to practices. In July and August 2020, the AMA surveyed 3,500 physicians. 81% said revenue was still lower than pre-pandemic, with an average drop in revenue of 32%. Compounding the financial stress of lost revenue, practices are also incurring additional costs for heightened infection control protocols and personal protective equipment. The AMA continues to be strongly supportive of the option for physicians to be held harmless under the extreme and uncontrollable circumstances hardship exception due to COVID-19, and we appreciate that CMS extended that application through February 1st and made an announcement on this town hall. We urge CMS to remember that physician practices are struggling to keep the lights on as they focus on treating patients during this prolonged emergency, and to maintain traditional MIPS and gradually phase in MVPs, allowing for a transition period so physicians who opt into MVPs as early adopters are not unfairly penalized in the program's infancy. Thank you.
Great, thank you, Jennifer. Okay, as a reminder to everybody who's registered to speak, if you could keep it to 5 minutes, your feedback to 5 minutes, that'd be appreciated so we can have time for open feedback if possible. But what we'll do is move back to Laura Vera from the American Academy of Dermatology. So Laura, your line is unmuted and you may go ahead.
Great, thank you so much. And I apologize for my earlier technical issues. I will try to be as quick as possible, but there is a lot to unpack here in this section of the town hall today. So bear with me while I try to make it through. First and foremost, we really appreciate this call and that you are listening to stakeholders' concerns and comments regarding MVPs. The American Academy of Dermatology has members in various practice settings, from solo to small and large dermatology groups, multi-specialty, as well as academic and hospital settings. We also have subspecialty areas to consider when we are creating our measures and the future MVPs. Our members continuously express concerns regarding the time and the resources required for MIPS reporting, and we are hopeful that MVPs will reduce this burden. However, it is challenging to understand the potential impact on our members until we really move forward in creating and implementing the MVPs. We believe that demonstrating the value of MVPs to reduce this burden, and with clear expectations from CMS around MVP participation, that we will be able to successfully engage our members in participating. But the Academy has concerns that we may only have one MVP for a few years. So we would need to work with you on creating a cost measure that would be applicable to the MVPs that we want to create, while continuously developing, testing, maintaining our existing measures. We also have an internal review process, and of course, we have the deadlines with CMS to submit measures for consideration. And then also we will then have this new timeline with submitting MVPs for review and approval. So I'm concerned about the discussion regarding retiring traditional MIPS, and do not think the traditional MIPS should be retired until there is adequate MVPs available to our members, which again is a challenge given the resources and costs and timelines for this creation. It's not clear when the traditional MIPS would retire, and I know you said that you have not shared that information or really don't have anything set in stone, but I just ask that these timelines be taken into consideration so that there's plenty of time for stakeholders to successfully create enough meaningful MVPs for their specialty. Regarding COVID, so COVID has greatly impacted our members, many implementing telemedicine for the first time, and has greatly affected their practice financially as well as their workflow. Some members will not be reporting or seeking exemption until the public health emergency is under control. And I do not think that there would be interest in an MVP until our members feel more comfortable. And I agree with the previous statement that was said that to consider maintaining traditional MIPS as long as possible due to this public health emergency. We also have members that request assistance in identifying members, which members would be best for them to report. And while I do think MVPs will assist in kind of packaging those measures for them It may also narrow the focus to a specific skin condition that they see rather than the various areas in which they practice. So we have concerns around that. It would be great if there was flexibility regarding patient engagement for stakeholders to share how they engage patients and what way works best for them. So for example, we have patient representatives involved in our measure development process. It adds incredible value to our measures to have them involved, and we hope that their involvement in measures for the MVPs would suffice. Like we wouldn't have to have additional patient review or approval or say in the MVP because it was involved in our measure development process. And we are considering condition-specific MVPs to look at overall care for skin conditions and procedure-based MVPs, and believe that there would be value of MVPs that focus in different areas that best represent the specialty. So I know that that was a question posed earlier. We do have concerns and questions around when parts of the MVP might be topped out and how that would be updated with the CMS timelines and review. So for example, if we begin with a melanoma MVP and some of the measures are topped out or up for removal, having enough time to replace those measures or consider different improvement activities or what it might be to be able to strengthen the MVP over time rather than kind of constantly scrambling with having to balance these different areas within the MVP and how that can impact our members because of being able to pick measures for reporting and that changing each year and so forth. So that was all I had for right now.
Great, thank you, Laura. All right, next up for feedback, we have Colleen Scow. Colleen is speaking from the College of American Pathologists. So Colleen, we've unmuted your line and you may go ahead.
Hey, can you hear me?
Yes, you're a bit faint if you would like to turn up your volume.
Oh, sorry about that. Having some problems with my audio. Hopefully that's better. So thank you for the opportunity to speak. As you mentioned, I am representing the College of American Pathologists, which is in fact a non-patient facing specialty. So I think we represent some of the clinicians that you had specific questions about and some of the specific concerns about how to include the patient voice and patient representation in the development of MVPs. And, despite being non-patient facing, obviously we value the input of patients. We value what patients want to know about pathology, hear about pathology, and what matters to them about pathology, whether that is how fast they receive their results, how clearly their results are written, whether they have access to the pathologist. We certainly value knowing what patients want. I think when it comes specifically to MVPs, we would encourage CMS to take as broad a view as possible of patient representation and the patient voice. To repeat a point that Laura just made, if patients are involved in developing measures, hopefully that would suffice for including the patient voice, even if the measures themselves are not patient reported measures or patient experience measures. To speak a little bit to how MVPs relate to APMs, again, as a non-patient facing specialty, there are no APMs which address pathology. Many pathologists are MIPS eligible, others are in ACOs, but there are not pathology APMs. So I think we would be interested in hearing more about CMS's ideas regarding the value of categorizing MVPs who, whether they are related to an APM or not related to an APM, whether CMS sees value in that kind of categorization for clinicians, for CMS, for organizations. I think maybe coming from a perspective where there are no APMs, it's a little hard to see exactly how that would have value. In terms of other ways to sort of categorize categorize MVPs. One thing that we would suggest is possibly if there was a way to identify related MVPs, particularly with respect to the discussion this morning about multi-specialty groups and the ability of multi-specialty groups to report as subgroups and yet also maintain, team-based care and avoid in any way pitting clinicians against each other. If there was a way to identify related MVPs that would allow subgroups to all report on, for instance, lung cancer related measures or something like that, it could have value in allowing cohesion even among subgroups. And then just finally, with respect to retirement of MIPS, I think we absolutely reiterate the concerns raised by the previous groups about, the deadlines and the steps necessary to create an MVP are fairly extensive, and we just don't see the ability to retire MIPS in the near future. Hopefully, I think from our perspective, and again, getting back to a point that was mentioned this morning, it is not just a matter of the number of MVPs which are available, but also having a sense of how those MVPs are going. So we wouldn't want to see traditional MIPS, sort of phased out as soon as MVPs become available without having some time to ensure that those MVPs are working as expected, are in use, have undergone some kind of, for lack of a better word, testing or piloting or something like that. And related to that, I think just as we sort of assume right now that clinicians select quality measures that they are able to report on, that they have, the case minimum for, I think there will always be some responsibility on the clinician's part for selecting an appropriate MVP. However, I would highlight that this is, another consideration as organizations are developing MVPs, not only to develop the MVP and make sure that it is feasible and valid and important for the clinicians, but also to simultaneously be thinking about how we educate our members, how we educate the clinicians about who this MVP would be for, who would qualify for this MVP, I think is, again, another sort of step along the process, which might extend the timeline of having an MVP available for everyone and perhaps, make the phasing out of traditional MIPS a little bit slower. So thank you.
Great, thank you, Colleen. All right, next from the American Academy of Ophthalmology, we have Molly Peltzman. So Molly, we will go ahead and unmute your line. If you could unmute from your end, you may go ahead.
Hi, can you hear me?
Yes, we can.
Okay, great, thanks. So the Academy supports the value pathway concept, but as everyone has said, it's still being developed and it is untested and it doesn't have the evidence of patient outcomes that many registry measures under MIPS already have. And so there's also a tremendous burden on clinicians for the administration of patient-reported outcome measures in terms of survey administration and collection on registries for collating and scoring. And so there's no added resource for this. So we do see that as kind of a barrier. And the MVPs provide some choice of measures, but we in our QCDR have 30 subspecialty quality measures and then an additional 13 ECQMs and 15 QPP measures to cover one single specialty of ophthalmology. Ophthalmologists as a group do not evaluate and treat the same disease, so we really require all of that option. And we're fearful that the MVP would not cover all of that by 6 measures. So we agree with everyone who's saying, we don't really want to retire traditional MIPS since our practices have been so successful with it and they require that choice and we're able to support so many or multiple subspecialties within ophthalmology. And then just one other kind of aside is that in the MVP program, since a lot of our ophthalmologists do not report or have claims for the cost category, we would suggest that be reweighted for clinicians who don't meet the threshold in MVPs as well.
Great, thank you, Molly. All right, next up we have Janelle Martin. Janelle Martin is speaking from the American College of Rheumatology. So Janelle, if you would like to unmute your line, you may go ahead.
Great, thank you so much. I'll echo everyone's thank you for the opportunity to give comment. I wanted to address just a couple of topics. One that Dr. Schreiber referenced kind of at the very start of the call that we haven't talked about a whole lot, which is the idea of potentially trying to think through how we might include more information or be a little more inclusive around the social determinants of health into the MVP or into the QPP more generally. We have a risk-adjusted outcome measure that we've developed. We're using the area deprivation index to try to at least address those elements in some way. But would love to hear more from CMS on that topic along the way, and try to think through how potentially we can incorporate that more as we continue to develop MVPs and moving into APMs. And that sort of thing. I know that there was a little discussion around how to incentivize providers to use MVPs instead. That might be a good way to incentivize them to offer maybe additional points or different scoring for those who are working with patients who have real challenges from a socioeconomic status, things like that. So we are interested in having more conversation around that point. The second element that I wanted to mention is really echoing several other folks who have spoken around the patient voice. We certainly want to incorporate that, but also encourage CMS to continue a more broad definition of what counts as a patient voice. Many of us on this call have a job that is primarily centered around understanding what quality of care is, how it ties to value-based reimbursement, distilling the QPP into action steps and that sort of thing, and to get a patient genuinely informed enough to provide meaningful feedback on an MVP that you've developed is maybe a tall order for them, a big ask. So considering that the patient voice to be continue to be considered through PROs, through development of outcome measures or patient safety measures, we feel like that those are more meaningful ways to incorporate the patient voice than trying to give them a crash course in quality of care and then get their feedback on a specific MVP that has been developed or something along those lines. So those were kind of two key pieces that we wanted to mention. And again, thank you for the time.
Great, thank you, Janelle. Okay, next to speak is Kevin Wong. Kevin will be speaking from the Hospital for Special Surgery. Kevin, it's all yours.
Hey, thank you. So I just want to reiterate the support for amplifying the patient's voice and increasing that definition, specifically around concepts such as patient goals, goal concordance in the processes of care, as well as shared decision-making. And it's encouraging to see that CMS, under the measures under consideration, has total hip and knee replacement patient-reported outcome measures that are both risk-adjusted as well as adjusted for response bias. But I think because of the lack of PRO measures available through MIPS overall, some of the measures require proprietary surveys, such as from Photo. We think it may be beneficial to increase the availability of patient-reported outcome measures and the inclusion of patient voice using QCDR self-nominated measures, regardless of whether or not the physicians are actually reporting into the QCDRs. I understand there may be some technical and licensing issues there, but I think increasing that flexibility with relation to the QCDRs and self-nominated measures will be really important to making sure there's as wide a variety as possible. In terms of MVP alignment with APMs, I think it's a big important point, just because there are, for example, with BPCI Advanced, certain measures done on a population basis, such as hospital-wide readmissions or PSI 90, that even though they are good quality metrics, may not be appropriate for the specific conditions being treated. So for example, if there is a high PSI 90 due to general surgery quality, that shouldn't necessarily affect the performance of spine and joints. And so that is a concern I have and that HSS has with the use of hospital-wide 30-day readmissions as a population-wide measure. And so I think that should be revisited as feedback for how these MVPs should be aligned, just in terms of currently existing APMs, as well as for the MVP alignment with clinicians. I think one way to reduce the burden of clinicians trying to sort through which MVPs work for them and which ones don't, especially if they're going to be multiple subspecialty based MVPs, is that there should be some method similar to the eligibility criteria where physicians are given options based off their prior year's Medicare beneficiary care patterns to say that they are eligible for X number of MVPs based off the patient populations that they see. And that could help to both balance the methodologies that are being proposed with these MVPs versus just pure self-assignment and the burden that's associated with kind of going through all of the MVPs to figure out which measures work for them and which ones don't. Just because certain measures, even such as the total hip and knee patient-reported outcome measure, are pretty complicated in terms of their specifications, in that it's not just collection of a single prom before and after a certain time period, but additional information needed for that risk adjustment. So these are just some of the comments that we have, and we look forward to hearing more. We are a bit worried that because the deadline for submitting MVP candidates is so soon in early February, as I think was proposed, that some of the MVPs may not be as thoroughly vetted, or that there would be a limited number of MVPs to be chosen, and that could reduce the uptake and success of MVPs down the line. So we think that further clarification or an additional time period for second calls or third calls would be really appreciated as part of it. All right, thank you. Hope I stayed within my 5-minute time frame.
Great, thank you, Kevin. All right, next we have Brian Bamstead, who will be speaking again from Molina Health. So Brian, you may go ahead.
Thanks. Good afternoon. This is Brian Vomps again with Molina Health. We're based out of Minneapolis, Minnesota, and our large multi-specialty health system. And just want to make a couple of high-level comments that were kind of said this morning from our opening statements, which I think really stuck with us, and I wanted to just raise, and then also a couple comments regarding the transition to APMs. The first thing that was mentioned this morning that I wanted to just reiterate here was talking about health equity. And I wanted to raise that I think that this is an important piece to this and should be incorporated in some way in the future program, or at least in your strategic framework. Diversity, equity, inclusion are very important activities for us at Allina, and it's something that we would appreciate being worked into this program moving forward in some way, shape, or form. In addition, another comment that was mentioned was about trying to move forward into the digital quality measures. And we understand that that is a transition and that will take some time, but overall I think it's a good direction to take. One of the challenges is that digital measures are not necessarily set up for all types of sub-level reporting, or types of specialty measures are not well set up yet. So moving in that direction I think is good, but it is going to take some time. A reasonable goal to achieve this would help ensure and usher transition to MVPs and ultimately to APMs, which we understand is the direction that CMS wants to go. But if healthcare is to succeed in really true interoperability, digital reporting is required to have a common language. And so that's why it is imperative, as stated earlier, to keep MVPs voluntary moving forward. With APMs, the movement from MVPs to APMs, that when APMs first rolled out from the Affordable Care Act, many organizations, including Allina, we participated in an ACO track. We no longer do, and we learned a lot from this experience. And while now MIPS is the program we are in, we of course are exploring and are interested in new APMs. And as this program has gone through iterations, starting from the physician value-based payment modifier to now the quality payment program, MIPS, et cetera, there appears at times to be a gap between the MIPS structure and APMs. And we know that CMS has tried to bridge this with known as MIPS APMs to try to transition that in the various ACO tracks from no risk to downside risk to try to fill this void. We would support that as a strategic alignment is to keep the measures, the structure, and the pathways from these voluntary MVPs toward an APM. So rather than developing MIPS or MVPs on one hand, and on the other hand, the Innovation Center rolling out new APMs, to have that to be a little bit better coordinated and aligned so that that pathway makes sense. And then the last piece is a challenge that at times brings about is when CMS drops mandatory APMs and then requires certain areas to participate. And that really sometimes puts a wrinkle in the whole strategic process about directions are going with APMs. All of a sudden you have a mandatory APM that you have to enroll in. You have to shift directions really quickly to understand that and be ready for that. So that's, as a consideration moving forward, the key points we like to make is one, develop these in tandem with the Innovation Center and what direction they're going with advanced alternative payment models, and to align the MVPs towards that in a way that makes sense, again, being voluntary, but in pathways that make sense so that we as a system, if we are looking at ways to move into the APMs, we'll have a better pathway to do so. So that concludes our comments, and we appreciate this opportunity again.
Great, thank you, Brian. All right, looks like we have two final speakers on this session. So we have Asia Shkola, who will be speaking for the U.S. Anesthesia Partners. Asia, you may go ahead.
Thank you. One of the things similar to all the what the other comments that were made previous to mine were just that since we are specific to anesthesia, we would want to maintain and be able to adapt anesthesia measures by CMS, just because in the past few years we haven't seen a great adaptation of anesthesia measures by CMS. We do have our AQM measures that we do submit to CMS, which do tend to get retired pretty quickly, maybe even year to year. So I think having that sustained measures throughout would be really helpful, just because that would really reduce the cost and the IT infrastructure that we've had to maintain because of those changes year to year, and just because adaptation of a new measure does take a certain amount of time. So for example, if we get the measure, a new measure in January, it does take a month or two to get it adapted and get our clinicians to start attesting to that measure. Additionally, because we're a single specialty anesthesia group and considered non-patient facing, the one thing that we do request CMS is consider amending or redesigning the cost measure, specifically the MSBT cost measure. We request that maybe there should be a threshold, perhaps of at least 5% of cases where the cost measure is actually related to the anesthesia providers, maybe even a threshold of 35 cases, like raw number of cases, or the cost category should be reweighted to the quality scores, because for example in 2019 some of our TINs had less than 1% of the overall cases that we performed qualify for the cost measure, but we did get some scores, lower scores because of that. And especially with some TINs, some of our TINs not even reaching 35 cases. Just like how other folks have mentioned on the call, we also feel that traditional MIPS should not be retired considering COVID and all the other reasons that have been stated by the rest of the town hall members. Thank you so much.
Great, thank you, Asia. All right, finally we have Suzanne Joy. Suzanne is speaking for the American College of Physicians. And Suzanne, yep, if you'd like to go ahead, your line is free.
Great, thank you all so much. I have 5 minutes exactly, so I have no choice but to stay under. I'll just echo thanks for the opportunity for this session. We do appreciate it, and we all agree. I think stakeholder input is critically important to the success of MVPs. ACP was actually responsible for submitting 2 MVP proposed bundles last year. We were one of, I think, only a few organizations, and So we definitely support where, the strategic direction of where you all are going. One of ours was on preventive care, which was mentioned earlier. One was on chronic disease management. And we've since appreciated the engagement from CMS. We've had a couple of phone calls and some emails, and we have one more scheduled on the horizon. And there are still, a few areas I know we've kind of gone back and forth, and, we're looking for some common ground, and we just look forward to continued productive conversations on that front. And from that process, I think we've gleaned some key insights that I'd like to share here today. First, just for those of us that did kind of get in the chute early, it would be great, which I know you guys have expressed, to just get some guidance on kind of what the path forward looks like, especially with kind of the new criteria that were added in the last round of the fee schedule rule. And then more generally, we definitely appreciate you guys kind of hearing the frustrations with MIPS and kind of taking an opportunity to take a step back and sort of think about what the best path forward looks like. And we definitely support the goals of the MVPs to be more patient-centered and to have more clinically relevant metrics, not only for patients, but also clinicians. And then, like we all talked about already, to create more synergy between those categories, get rid of some of those silos, and then facilitate the transition to APMs. We do think that at this point, what the MVPs are kind of shaping to look like are looking a little more like traditional MIPS, particularly some of the MIPS specialty bundles, than perhaps kind of an overarching new approach. And we do think that there is some room to create truly more synergy across the categories. We're not asking for you all to kind of lift requirements or make it kind of an easy pass program. We're just saying that if you do an action that inherently sort of has data that can be counted towards two different, performance categories, don't make someone kind of do an extra action on top of that just to check a box. I think a perfect example is, reporting quality data through an EHR. You get your quality data, and then in so doing, you're inherently demonstrating you're using the EHR. So just looking for opportunities like that. In general, for the PI category, which is that kind of EHR usage category, we would support more of an overhaul for that category. And what we've suggested is something that looks a little more kind of resembling of the improvement activities category, that captures some of the more dynamic ways that practices are already using so much health information technology, not just through EHRs, but registries and virtual and artificial intelligence. It's a burgeoning landscape, and we think doing it that way will capture what's already going on, and it will really importantly allow the category to kind of continue transforming into the future. We understand that you all are open to kind of wider transformations in the future, which you guys say in the rule with the promoting interoperability measures and the cost measures, and we appreciate that a lot. I guess our standpoint then would kind of to what some of the earlier people were saying about timeline. We're not sure if kind of taking the step forward in 2022, where then you're going to make these other large scale changes in the future, is necessarily the best path. We really think this is an important opportunity, as earlier speaker said, to really take a step back and evaluate. And we don't want to see continuous change. Clinicians are exhausted, which is part of the reason we're here in the first place. So I think if we're going to do this, we do it once, we do it right. And if you are open to kind of more innovative approaches to the promoting interoperability and cost categories, that's great. That's what we want to hear. We would love to do that and talk to you about it prior to MVP implementation and do it from the start. Even if that means, maybe delaying those first MVPs a little bit, we think it's important to kind of do it right. In terms of some of the really specific questions, we agree with the idea of the bonus. We think less reporting of measures will incentivize participation because it's less burden. We, like others, support the voluntary selection of MVPs. And we do support you all exploring, and definitely noting which MVPs might lead to existing APMs. We think that's useful to show people the glide path, but we just want to be really careful that that doesn't mean that we neglect other areas. Certainly, low-hanging fruit, if there's already a specialty measure set, if there's already an APM, and it's kind of an easy lift to design an MVP, certainly move forward. But I definitely think identifying gaps and kind of addressing them is really important. And the last thing I'll say is that, like others, we do not support retiring traditional MIPS. We actually don't think it's necessary. If MVP is successful in its goals of reducing burden and being more clinically relevant, physicians and patients are going to want it. So we don't think it's necessary. If you do move forward, at a minimum, we would just ask, as others have, that you don't do so before making sure there's a wide array of MVPs, particularly for certain specialties, and that there's some sort of a threshold, and only a very small minority of clinicians are still in traditional MIPS when you make that transition. So again, appreciate the opportunity and looking forward to more discussions for session 3. Thank you.
Great, thank you, Suzanne. Okay, it looks like that concludes our scheduled feedback for session 2, so we will turn it back to Molly McCarris.
Okay, thank you, Lauren, and thank you so much for all of our commenters or stakeholders who were able to provide us feedback during this session. We unfortunately do not have the time to open it up to the rest of the group at this juncture. We do have a number of folks who have asked to speak for our last session, but what we will do is, if there is time at the end, we will broadly open up the opportunity for folks to give us feedback on any of our sessions. Additionally, if anyone does have any feedback that they did want to share for our second session that they were not able to share today, again, please submit your comments to us in writing. You have until next week to do that. Also, if you wanted to share anything informal or quick with us today, I think the vast majority of folks have mine and Sophia's email addresses, so feel free to send any of that information over to us directly and we'll take a look at it. So with that, let me go ahead and turn it back over to Lauren to tee us up for moving on to the next and final session that we have today. Thanks, Lauren.
Okay,
and I believe,
go ahead.
Sorry, Lauren, I was just going to say, I believe Sophia is handling session 3.
Yep, thank you, Molly, and thanks, Lauren. So before we get started, and I just want to tee this up because I know in the last session, based off the feedback, we got a lot of information, or a lot of questions around the development timeline. We did in December have that MVP development webinar, and I do encourage those that did not attend that to go and listen to that recording. If it's, I believe it's posted, but if it's not, it should be relatively soon. To get more information about that timeline of when we would accept MVP candidates. I just want to emphasize that there is no, while we did mention at the webinar, we would accept MVP candidates that up until the end of February to be considered for 2022. I want to emphasize that we'll accept candidates on a rolling basis. So even past that point, if you need more time to work through the logistics of your MVP candidate, certainly take that time to do so and submit them on a rolling basis, even if it cannot be considered for 2022 based off of our timeline constraints. Certainly we can continue to look at them as, we plan for future years, and there is no, you must submit by then or won't be looked at all. We do not have that perspective or lens as we receive these candidates. We're trying to be as open as possible and really want to hear your ideas and what you come up with. So I just wanted to caveat that because we, through that development webinar and working with many of our stakeholders thus far, have received a lot of questions related to session 3. And so I think this is pretty much a session that a lot of people are anticipating to hear about and also provide input on. So let's get started on the next slide, please. Okay, so within session 3, similar to the previous format, we have 4 topics we're going to cover today: MVP reporting requirements, measure objectives within the quality performance category, and that's within the quality component of the MVP reporting example, and then also an MVP scoring outline of our thoughts on what we think MVP scoring could look like. So there is additional information about all this within the Town Hall preparation guide that is posted on the KPP resource library. So if you haven't already taken a peek at that, please feel free to pull that up as we go through the slides. We are going to continue the conversations we've had today, and in this session describe in detail different areas of consideration we are looking at for MVPs and how MVPs can function. So far what we've been tracking to is that we've heard is that MVP should be voluntary. They should account for ensuring that there's reduced reporting burden, and that we consider that there needs to be some scoring equity as we consider the different types of MVPs that will come and build up our inventory of MVPs. They need to contain also meaningful quality and cost measures that allow participation for all eligible clinicians in MVPs. And also, again, as mentioned by stakeholders and was previously mentioned in the last session, remove reporting and scoring silos between performance categories to simplify participation. So here in this session, we try to address those, and we certainly are looking for feedback from you all as to thoughts or any concerns you may have with some of the concepts or ideas we've come up with thus far. So let's move to the next slide. Okay, so with regards to MVP scoring, this is what we're considering when we think of the 4 performance categories that exist within traditional MIPS and how that would translate over into MVPs. For the quality performance category, clinicians will choose from and report on a set of measures amongst the quality measures available within the MVP. In addition to the quality measures they choose from, within the foundational layer will be those population health-based measures that will be calculated and that will be attributed to the quality score. So the quality aspect of MVP would allow for some choice for clinicians to choose from a limited number of measures and then be scored accordingly. Within the improvement activities performance categories, clinicians would be able to choose from a curated list of improvement activities and select either 1 high-weighted activity or 2 medium-weighted activities, and that's all they would be required to report for the IA component of the MVP. Within the cost performance category, we would like to establish a minimum that any MVP would have at a minimum 1 cost measure, and the measure would be calculated accordingly. For promoting interoperability, we would include the entire set of promoting interoperability measures, which would be as a part of the foundational layer. So clinicians would report the same measures required in the traditional MIPS program. That would be a part of the foundational layer of the MVP. I do want to caveat here that the existing exemptions that we have under traditional MIPS for certain clinician types who do not need to report promoting interoperability measures would carry through as we move to MVPs. So there would not be any distinction from that those same exemptions would continue as we move to MVPs. Next slide, please. Okay, and when we look at the reporting requirements for each of the performance categories and think of that as we talk about MVPs, when we talk about quality and the quality component, I'm sure all of you have seen our diagrams of what an MVP could look like in the future. And as a part of that, there are specific measures we've called out specifically for quality. Moving away from our traditional confines of requiring 6 measures, reducing that number to be 4 and giving clinicians the option to select which 4 measures within the quality component of the MVP to report gives them some choice, but then also narrows those choices to more meaningful measures for a given clinical concept that we're trying to measure. And also having to reduce fewer measures possibly works as an incentive to move clinicians from traditional MIPS to the MVPs. The area within quality that we would not require submission is for those population health measures again, for which those measures would be a part of the foundation, essentially what we refer to them as MVP agnostic, being the same across all MVPs. So we would calculate the measure, at least 1 for each MVP, and that would be separate from the measures that you select within the 4. So that would be in addition to. So essentially that's 5 measures for quality, but 4 you get to choose. For improvement activities, as I previously mentioned, there would be a list of improvement activities. The clinician would choose either 1 high-weighted or 2 medium-weighted, and that's all they're required to report for IA. Cost, again, there's no data or reporting burden on the clinician. We calculate these measures. So cost measures, 1 cost measure must be included in the MVP at a minimum, and the cost measure would be calculated accordingly. And then again, the PI performance category would be included in the foundation. All measures would be reported on. The only exemption to that are those clinician types that are currently exempted under PI. We would carry those same policies through for MVPs as well. So as that changes for traditional MIPS, it would carry on for MVPs. If it's the same, then that's what it is. If you're currently exempted from PI within traditional MIPS and that exemption doesn't change, the same exemptions would apply for MVPs. Next slide, please. So within quality, we're trying to look at quality in 3 different ways. Quality can mean there are measures that address improving care relevant to the clinician's specialty. And so what we think of these as those highly specialized, specialty-specific measures that are very specific to a procedure or a clinical topic, something that would not necessarily be meaningful to other specialties, more relevant to a given one. And they're essentially not, more clinically relevant. The second category are those patient voice measures that we've talked about before, and patient voice is a broad term. We tried to keep it broad because, it's not just patient-reported outcome measures. We do want to acknowledge that there's patient survey measures that are, relevant, also patient-centered measures that are, relevant to patient safety and patient experience. That could involve shared decision-making and advanced care planning as well. So measures that fall within that broader category, not necessarily all patient-reported outcome measures, though that is an area we would like to see our library of measures expand in. Having measures that reflect the patient voice is another group of that would be represented within the quality component. And lastly, that population health within the foundation layer. Improving population health, again, those are the administrative claims-based measures that assess care for populations, would be consistent across all MVPs, regardless of focus. Again, referring to those as MVP agnostic. That would be another component within quality, but separate from the other 2. So when we think about the scoring of quality, we're considering creating these 3 buckets here, and that each of these buckets within quality would have different weights for each measure objective. Next slide, please. So here we're trying to provide a visual of what could possibly, form an MVP and what would be expected of the clinician. So a given MVP, just talking in numbers, for the quality component could have 6 measures that are specialty specific, in which those measures are available through multiple collection types. So for example, we have measures that are specified as CQM or registry measures and ECQM. They could be Part B claims. They could be QCDR measures. The clinician would be required to report, let's say 3 of those collection types. There are 3 collection types available, and then the clinician has to report on 4 quality measures. So the clinician would have to report on the measures that are available through the collection type they intend to use. So to be clear, that would be the 3 measures that are, if there are 6 measures and only 3 of them are available through the ECQM collection type, and that's the collection type they intend to use for quality reporting, then that's what they're expected to report. For the patient voice measure, there's 2 measures reflective of the patient voice. The clinician would be required to report at least 1 of those measures. So they get the choice between those 2, and then they decide which measure is more relevant to them, and will submit the data for that 1 measure to get to the 4. Following that is the population health measure, which is again in the foundation. That will be automatically calculated. It would not require any data submission on behalf of the clinician. And then when we move from quality to IA, you have within the MVP, there are 8 possible improvement activities. The clinician found that there are 2 relevant improvement activities that are both medium weighted and have decided to report on those 2. That's all that's required of them. Alternatively to that, if they found only 1 high weighted activity that was relevant to them, they could just report on that one high weighted activity, improvement activity, and meet the improvement activity reporting requirements for this MVP. For cost, there were 2 cost measures in this MVP example. Both cost measures would be automatically calculated, and reweighting would be possible if no cost measures could be attributed to the clinician. So in a sense, if we've run the numbers and we've come to find that either the clinician doesn't meet the thresholds that are needed for cost measure calculation, then that weight would be redistributed or reattributed to another performance category. And as I mentioned before, the promoting interoperability measure set, which is included again in the foundational layer, we would be required to report all measures within the PI set. However, clinicians that qualify for reweighting for PI within the traditional MIPS route would still qualify for that reweighting here and could still report on an MVP even if they are exempt from PI. Next slide, please. Okay, so for MVP scoring here, we will have the same performance category weight as traditional MIPS as discussed in the scoring guide, but for quality performance category scoring in MIPS, we envision that we will score each measure from 1 to 10 points. As Molly has mentioned previously, we are not anticipating any bonus points for MVP reporting because we want to measure clinicians based on performance without score inflation. Again, we've heard certainly some feedback on that is already, but open to more feedback from you all as to your thoughts there or how we can possibly address that, our concerns with regards to score inflation, because of bonus points. If you have a mitigation strategy for that, we're certainly open to hear it. For costs, we do envision that we will score each measure from 1 to 10 points, so that cost measure cost score will be dependent on how you score on the measure itself. And again, within traditional MIPS, I believe there's calculation across the board for all the measures, but here there will not be. It will just be dependent on what is within the MVP itself. For improvement activities, we do envision that we would follow the special scoring rules in traditional MIPS where activities are worth double the points. And for PI, we envision that the scoring would stay the same as we do have in traditional MIPS. And if a clinician reports both an MVP and reports on traditional MIPS, we do anticipate we would take the higher of the final scores from both reporting options. And I believe that was something we heard some positive thoughts on earlier on during this session. We did receive requests from stakeholders to guarantee that clinicians reporting an MVP receive a neutral or a positive payment adjustment under MIPS without potential to receive negative payment adjustments. We do want to note that that's not something we have, we can possibly do under the current statute, and we must maintain assessment under the 4 performance categories and then have a composite score. Next slide, please. Okay, so in the next 2 slides, we're just going to tee up these questions for you all, just as a reminder, and then we will, certainly open up the lines to start the feedback session. The first set of questions are related to reporting requirements. We have heard from stakeholders that clinicians want the ability to select measures and activities within the MVP for reporting purposes. So under this consideration, if clinicians have a choice to select measures and activities in the MVP, how do we ensure that the clinician selects an appropriate MVP? Appropriate in the sense of clinically relevant, it's meaningful to them, it's not that they will just do the best on these measures. Is it reasonable for CMS to assume that clinicians electing an MVP will report on a minimum number of measures or activities for cost, quality, and IA, recognizing that PI is included within the foundational layer for all MVPs and thus will also be reported? And I guess the underlying caveat there is, with the PI exemptions that exist, that will carry through with MVPs as well. If not, what are the alternative assumptions we should be working under? We've also heard clearly that clinicians and groups want choice, yet the program want choice yet want the program to be simple. Under this consideration, are there other ways we can maintain a degree of flexibility while achieving greater simplicity through MVP reporting? Next slide, please. Okay, so with regards to this next set of questions related to the measure objectives within the quality performance category and those three buckets we've previously teed up in the earlier slide. We noted in an example above to illustrate how the objectives within the quality performance category could be weighted. How should the objectives within the quality performance category be weighted? Do you believe we should put more weight on the specialty-specific measures over the patient voice, or should patient voice take precedence, or population health? You know, really thinking of those three buckets of measures, how would you weight those if it was up to you? Do the objectives we are considering adequately address the MIPS priorities? Are there any other objectives we should be highlighting instead of the ones we've selected? Should we allow objectives to be reweighted if a clinician does not have a sufficient case volume to report? So right now we have scoring rules in traditional MIPS that account for if case volume cannot be met. Is that something we should look at differently when we look at these objectives within quality? Should we require the clinicians to report on a minimum number of measures in the objectives? So for example, within improving care relevant to clinician specialty and in patient voice, should we say you must report 2 measures that are relative to each of these objectives, or should it be something else? Or how should we quantify that? Should measures have a different number of available measure points similar to how the PI performance category works currently under traditional MIPS? And we anticipate there may be a time when we require reporting, such as a measure related to a public health issue, by everyone who reports an MVP. What kind of measures should be required for MVP reporting in your thought, in your suggestion or recommendation? Next slide, please. All right, this set of questions is specific to MVP reporting requirements. Are there any concerns we should take into consideration on including only a subset of improvement activities compared to having the whole inventory of improvement activities that is available in traditional MIPS? I think that's something we're curious to hear. We try to set up MVPs to reflect subsets that are more relevant to the clinical topics, but if you feel like there are any concerns we should consider, certainly something we are open to hearing about. We also anticipate that it will take some time to identify and develop applicable cost measures for all clinicians and specialty types. So under this consideration, what do we do in the interim for those MVPs in which clinicians do not have applicable cost measures? And how do we develop MVPs for non-patient facing clinicians? I think that's something we've heard from our non-patient stakeholders earlier today, and it's something we certainly have in our minds as well, developing meaningful MVPs for those non-patient facing clinicians and ensuring they are just as equitable to those that are patient facing. Next slide, please. Okay, with regards to scoring, in the absence of bonuses, are there adjustments we need to make within traditional MIPS or MVPs to facilitate equitable scoring? And are there any scenarios where we would consider reweighting the cost performance category for clinicians who do not meet the case minimum for cost measures that are included in the MVP? If not, should we require that clinicians report on a different MVP or traditional MIPS if they don't meet that case minimum for a cost measure within the MVP? Should we develop MVPs that anticipate reweighting of the PI performance category, given that this category has been automatically reweighted for certain clinician types, including but not limited to physical therapists, occupational therapists, speech language pathologists, and registered nutritionists? Sorry about that. Next slide, please. Okay, I think we're about ready to start the participant feedback part of the session. So Lauren or Lindsay, I'll turn it over to you.
Sounds great. Thanks, Sophia. All right. Again, we are going to start with the scheduled feedback session. And if we have any time remaining, we will open it up to more open feedback. If at any time you would like to provide feedback and can't do so on the current town hall, please do feel free to send all written feedback to the CMS MVP feedback inbox. It's cmsmvpfeedback@ketchum.com and will be shared as an announcement. Okay, so first we will start with Jeffrey Davis, who is speaking from the American College of Emergency Physicians. So Jeffrey, we will unmute your line, and if you'd like to self-mute, you may go ahead.
Can you hear me?
Yes, we can.
Great, thank you so much. Well, thank you, everyone. Thank you, Sophia. Thank you, Molly. Thank you, everyone, for hosting today. This has been great. I've learned a lot, and again, thank you for your work on this. We think that at ACEP, and agree with others that moving towards value in healthcare really involves quality and cost, and they're both an equally important component towards driving value. And just to get into the cost area a little bit, right now there are really no cost measures available for emergency medicine, for emergency physicians, and we're thinking about developing. As we think about developing MVP, we are concerned about that. To the question regarding cost measures and what happens in the interim when there are no available cost measures, we do want to get moving. We do want to put an MVP as soon as possible, and perhaps for 2022 or later. But we won't have any episode-based cost measures available by then. The Acumen process, I think Acumen is now going through waves of measure development, cost measure development, and they're thinking about emergency medicine cost measures, but that's going to be in the future. And I think that's something we're concerned about, is that right now we kind of box into the two available total cost of care measure and MSPD measures that are available right now under the MIPS program. And what happens when we do actually get, hopefully down the road in a year or two, an episode-based cost measure for emergency medicine? Do we have to go? What happens to our MVP if it is eventually developed? Do we have to? Do we have to go back through the whole process and get it reevaluated, or what's that transition point going to look like? That's a concern. I think CMS should consider creating kind of a guide path or some way of allowing a changing of measures, especially cost measures as they become available, to make it easy for clinicians to keep if they're reporting MVP, to keep able to report that MVP, but just transition measures as they go, particularly cost measures, and for cost measures that are not yet, for specialties that don't have cost measures available. Changing topics completely, I do want to just kind of put on a different type of hat here and talk about some of the scoring issues that you've identified, and also the ability. I would urge CMS to be creative, and I know that you said you are bound by statute in a lot of these respects, but I would urge you to work with your CMI colleagues and really think about Section 1115A, using Section 1115A of the Social Security Act, and using CMI authority to waive some of the requirements in Title 18 as you see fit, to really test what an MVP could look like in terms of scoring, in terms of being able to do cross-category reporting, or anything that you think is restricted by the current Title 18 statute in terms of MVPs. This is the future, as you pointed out, and I think you should really explore the ability to be creative and think about different scoring arrangements or different ways of reporting measures and see what works. Because again, if we want to transition from MIPS to MVPs and eventually, hopefully, to APMs, it's very important to be as flexible as possible, to really think outside the box, and to really use, and you're able to do that by using the CMI authority. I think it meets the definition of CMI authority. You're testing a model. Obviously you're not going to increase costs because this is a budget neutral program, and you could definitely improve quality by having targeted, by being able to really shape MVPs that really focus on things that specialists care about and physicians care about. I think it's definitely a good use of CMI authority. So I would consider CMS to think outside the box in that way. Again, I thank you so much for the opportunity to comment, and we look forward, ACEP looks forward to hopefully submitting an MVP and going forward, and thank you again for hosting today's session.
Great, thank you, Jeffrey. All right, next to speak, we have Angela Kennedy speaking for the American Society of Clinical Oncology. So Angela, your line is unmuted and you may go ahead.
Hi, this is Angela Kennedy, but just a quick clarification. Today I'm speaking on behalf of the Physician Registry Coalition, which is a 25 medical specialty sponsored and physician-led and physician-centric registry coalition run by Rob Portman, but Rob could not attend today, so I am providing these comments on behalf of the coalition. So these comments and questions are pretty focused on QCDR and registries or third-party intermediaries, and how can third-party intermediaries prepare and assist MVP participants, as well as provide robust and accurate data to CMS. So a quick comment from earlier around slide 13 and the questions regarding third-party intermediaries. We support and agree with the comments that AMA and ACR made about the ability to be able to support subgroup reporting. But an additional item to consider is that for many specialty societies, though the QCDR is in the specialty society's name, the QCDR is actually developed by a separate IT organization. So therefore, specialty societies often have little or no control over the software development for the added functionality, in addition to the functionality for selecting if you're going to participate in MVPs. We would request that CMS consider what the expectations are for CMS in terms of software functionality for MVPs. So for example, the modifications to the scoring to include population health measure and quality, or any of these changes proposed to the scoring and weighting, especially if the QCDR is expected to both provide traditional MIPS pathway and the MVPs. That's quite a bit of software reconfiguring on the back end, and it does take time for the software development process. So if CMS is expecting that any software changes be deployed by January 1 of 2022, we just ask that you keep in mind the timeline and also the additional cost for these software changes to QCDRs. So possibly that could be a phased-in functionality phased in over the course of the next couple of years. So also regarding the inclusion of QCDR measures in MVPs, so CMS has stated that QCDR measures could be included in MVPs, but the testing requirements for those QCDR measures would be comparable to the testing requirements for MIPS. So while CMS has provided the rationale behind the testing requirements, there are still a few questions that remain around the logistics of including QCDR measures in MVPs. And I think part of that also goes back to the scoring. Would QCDR measures still be only 3 points since they wouldn't be benchmarked? Would there be some sort of incentives for non-bench, for reporting on non-bench QCDR measures so that they could be benchmarked? Will QCDR measures for MVPs be submitted through the regular QCDR self-nom process? And for those QCDR measures that are approved for MVPs, will there be a special designation? Then I think there are a little bit more logistics that come along if you include QCDR measures in MVPs. So if there is a QCDR measure, and let's say a QR would like to offer that MVP to their participants, would then a QR be able to include a QCDR measure in their registry? I think all of this kind of goes back to conversations we had, I want to say in 2018, 2019, about the ownership rules for QCDR measures. So would the current ownership rules remain the same for QCDR measures if they're included in MIPS? So for example, if someone wanted to include a QCDR measure owned by another entity in an MVP, should they get permission from the QCDR measure owner before doing so? I think finally, like, these questions all impact the strategy and decision of measure development. And as mentioned in this program, that NCMS is also aware that measure development and testing is expensive. And I think we all have the common goal of having meaningful and valuable measures. The cost of measure development and testing is a significant barrier for many specialty societies. So the question was asked earlier about the impact of COVID, but it was somewhat more towards MVP participants and physician and practices. But it's important to note that specialty societies have also been significantly impacted financially by COVID, and running QCDRs and measure development and testing requires significant financial resources. So in terms of the impact of COVID, we suggest that you also keep in mind the impact on the specialty societies or those who are running the third-party intermediaries or developing the measures.
Great, thank you, Angela. All right, our next speaker is Corinne Rubin from the American Medical Association. So Corinne, we've unmuted your line, and if you'd like to unmute, you may go ahead.
Hi, this is Corinne Rubin from the AMA. Thank you so much for allowing me to speak today, as well as my colleague, Jennifer McLaughlin. I'm going to go over the reporting and scoring requirements, as well as the detailed questions that you've asked about the quality performance category. And given that these are pretty extensive questions you're asking, we also plan to follow up with written comments. First, in regards to the MVP reporting requirements, the best way to ensure simplicity, not require reporting on a certain number of measures, type or focus of measures, or assign varying weight. CMS has tried over the years to similarly structure the physician programs.
Hi, Corinne. We're so sorry, but you are cutting in and out. Just wanted to flag that if there's a way that you are able to fix your audio so we can hear everything that you're saying.
Oh, I'm sorry. Can you hear me better now?
Yes, that should work. Thanks.
Okay. Please let me know if I get cut off. Should I start from the beginning?
Yes, please. Thank you.
Okay. In regards to the MVP reporting requirement, the best way to ensure simplicity is to not require reporting on a certain number of measures, type or focus of measures, or assign varying weight. CMS has tried over the years to similarly structure the physician program, going back to PQRS, which resulted in an administratively burdensome program, confusing program, and regular complaint of reporting for the sake of reporting. Physicians are in the best position to determine which clinical area will be most meaningful to their practice, and it may be many years before MVPs exist for many physician subspecialties and practices. Now, in regards to the measured objectives within the quality performance category. The example CMS provided in the guide, as well as today on the slide, does not move the program to a more holistic approach to measuring quality. The structure appears extremely similar to existing specialty measure sets, and the intent of the specialty measure sets is to act as a guide to assist with choosing relevant measures within MIPS, not form a structure of a program or category within MIPS. The thinking is still very individualistic, as opposed to moving the program to be more episodic or clinically focused with a clear end goal of the desired outcome. As the AMA has repeatedly highlighted in comments and conversations with CMS and MVP, the number of measures within an MVP should be determined by the MVP steward based on the MVP's clinical focus and what is most appropriate to measure and improve patient care. Furthermore, the AMA is concerned with CMS's continued emphasis. MVPs must include population health administrative claims measures as a foundational layer. Population health measures move the MVP away from incorporating the patient's voice, measuring clinical conditions and outcomes, and generating real-time feedback. Measure developers moved away from administrative claims measures due to concerns over attribution, retrospective analysis, and inability to measure individual physicians and outcomes. We also do not believe CMS has considered that the implementation of population health measures will further diminish the viability of small practices. Now I'm going to move into the MVP scoring section. It's a little dense, and we also plan to follow up given complexity of the scoring rules. and the law. But we'll also follow up with written comments.
Hi, Corin. We're so sorry, but your sound has gone to the point where I don't think we can hear you properly. So what we're going to do is our colleagues will follow up with you individually to make sure we can get your feedback to the inbox so that everyone at CMS can review what you're saying. So sorry for the technical issues there.
Okay.
Okay, so what we'll do is move on. We have Laura Vera again speaking for the American Academy of Dermatology. So Laura, we will go ahead and unmute your line and you may go ahead. Hi, Laura Vera from the American Academy of Dermatology. You may go ahead and provide your feedback. Yes, we can.
Hear me? Okay, great. I was having technical issues, so I'm so glad. Thank you so much for allowing me the opportunity to share our comments again. Again, we will be following up with you afterwards with our comments as well. But we believe that that MVP is not a one-size-fits-all, and are concerned with the reporting and scoring aspect of MVPs. It would be best for our members if we do say something along the lines which you have alluded to in your documentation of, a minimum is to pick 4 out of 10 of these measures when the MVPs are first launched, allowing them for our clinicians to pick the best measures for them to report. We do have some members that will report the minimum. We have some that will report as much as possible, and allowing for that flexibility while our members begin to participate in MVPs will encourage participation. I can see the value of this becoming more structured over time, like, pick these 3 or these 4 or whatever it might be, but I think starting with a lot of flexibility there would be ideal for our membership. If the MVP is supposed to focus on areas that members need to improve rather than reporting what they are doing well or have sufficient case volume for, then that's a different way to guide MVP implementation, and this will change how we engage our members internally on the review and approval of MVPs for consideration. If we want to include improvement activities that are met by or align with measures in the MVP or practice workflow, versus including improvement activities to improve outcomes or care processes. So clear guidance from you all in terms of expectations around improvement activities in the MVPs would really be helpful for us as we move forward in the development of MVPs. Again, we do include patient voice in our measure development for all of our measures, even if that measure is not a patient-reported outcome measure. So I see the value in requiring a shared decision-making measure or patient satisfaction or patient-reported outcome measure to be required in the MVP, but we are working to create more of these measures, and this may delay MVP creation for us if it is required for them to report one of those measures in the MVP. We do support reweighting if a clinician does not have sufficient case volume for the cost measures, as well as reweighting for the promoting interoperability category if needed in MVP. And just to let you know that the Academy will likely not move forward with MVPs unless we have dermatology specific cost measures to be included in our MVPs, which we do not have at this time. And then lastly, I know comments were made earlier on behalf of the Registry Coalition, which we are a part of, and we agree with all of those comments made and would like for those to be emphasized. We do need guidance on data submission requirements for the registry and how this will impact our QCR measures, which we have spent a significant amount of time and resources on creating and testing and implementing. So that was all from the Academy. Thank you so much.
Great. Thank you, Laura. All right, next we'll hear from Suzanne Joy. Suzanne is speaking from the American College of Physicians. So Suzanne, we've unmuted your line and you may go ahead.
Great, thank you all so much. So we really appreciate you all being responsive to stakeholder feedback. We were reading through the materials you provided prior to the meeting, and you talked about kind of a change in approach and that you do plan to include an element of measure selection. So we just wanted to commend that and reaffirm that we believe that adding some measures and some options to choose does not increase the complexity of the program. because it's the same set of kind of universal requirements, but it is really important in that it minimizes reporting burden and helps to ensure that those metrics are clinically relevant to the specific patient populations, the medical conditions, and the specialties that these MVPs are targeting. We also support requiring fewer measures to be actively reported, which again reduces reporting burden. However, we have in the past, as I know others on the call have, voiced some concerns with some of the kind of logistical and methodological issues with some of the administrative claims measures to date. Including sort of attribution issues, a lack of actionability to actually meaningfully improve patient outcomes, particularly when those are measured at the individual clinician level. So we would, ask and expect that those issues kind of be discussed with stakeholders and addressed before being included in the future. We also appreciate that you all have a desire to, have some meaningful comparative metrics kind of more broadly, but, similar to what was said earlier, we do believe that, unfortunately that just sort of goes against sort of the point of MVPs to be more clinically relevant. We don't think the goal should just be to unilaterally compare specialties. They're different, and that's not a bad thing. And I think if measures are going to be clinically relevant, they do need to be specific to certain specialties, certain conditions, and certain patients. And that means they might not be comparable, across broad swaths of the country or specialties, but that's okay. And it's more important to kind of have that clinical relevance where you're really moving the dial and improving patient outcomes, and then giving actionable performance feedback and data, not only to clinicians, but to patients. We also feel that it's really important, my data wonk nerd side is about to come out, but it's super important that, measures are held to transparent, consistent standards for statistical reliability, as well as their ability to meaningfully impact patient outcomes that needs to be proven, and that they're upheld to clinical evidence-based standards. We do not feel that I'm getting some feedback.
Yes, we are going to work on that.
Okay, great, thank you. We personally don't feel, and we've said this in the past, that an average minimum reliability of 0.4 is sufficient, which is quite low, and we would encourage it to be more in the ballpark of 0.7 or 0.75. And we understand that that means less clinicians are going to be evaluated on measures, and that's not our goal, but we think evaluating more clinicians on flawed measures isn't really helping. It would be better, even if the patient or physician population is a little smaller, that whatever they are being measured on is statistically valid and provable. And if they're, especially when it comes to their payments being impacted, we just don't want physician payments impacted by measures that aren't meeting these kind of high reliability standards. ACP's own performance measurement committee has been evaluating measures for clinical relevance over the past several years. They found, it's a proportion of them to be invalid, and we do appreciate CMS recognizing some of the low value measures and removing them. We do, try and encourage to try and tweak measures, and we've offered some specific suggestions in lieu of just removing a bunch. We are worried that certain specialties in particular might be left without a sufficient number, so we just ask them to keep that in mind. But we generally, approve of that path of moving towards more relevant measures, and we kind of along that line, like others have said, we think that having relevant cost measures is really important, specific to conditions and specialties, and that are actionable on behalf of the clinicians, not these super high, broad downstream cost measures. And we understand that that's sort of in the future, and we appreciate you working towards that. One thing that I think is really important is, at the end of the day, who's going to pay for that and who's going to lead the charge on that. I think there's a lot of hunger and appetite for it. It's been clear here today. I know I talked to a lot of our subspecialty societies who are all willing to lend their expertise, but it's a big hill to climb, and we would certainly appreciate CMS leading those efforts and kind of forging ahead with that. And in the interim, that there's some room for improvement. Sorry, getting feedback again, so I'll just pause. And in the interim, we do think there's some definite room for improvement with some of the existing cost measures. I won't rattle through everything, but as I mentioned, evaluating at the group practice level or higher, not the individual clinician level, not attributing the same costs over multiple clinicians or groups, and then risk adjusting for social determinants of health, and of course, actionability on behalf of the clinician, something that is actually in their sphere of influence with the patient. Just a couple other things, which was brought up before, is QCDR measures. We support their inclusion. We appreciate that from CMS. I know in the final rule, you all asked that measures be fully tested and vetted prior to inclusion in a draft MVP proposal. And I totally understand the logic behind that. And we're not asking you to lower your standards whatsoever. We want really, high level and good quality measures. I guess what we're just saying is, I think a simple way to reduce the multi-year process is to allow those two processes to occur simultaneously. So while a measure is undergoing approval from CMS, it should be allowed to be included in a proposed MVP. And of course, before it's finalized, it would have to be finalized, the measure itself. So we're not asking you to lower your standards, just allow those timelines to occur simultaneously. Otherwise, we're going to have a multi-year backup in the MVP development process. And then finally, in terms of scoring, we definitely support you all, pursuing your own strategic priorities and kind of understand the logic behind that and the weighting, but we're worried that's going to create some complexity, which is what we're trying to avoid. So, I definitely think you can think about that and definitely kind of move in those directions, but before you move forward with formalizing any kind of subcategories, maybe just kind of that would be in the background, and you try and keep the physician facing side as simple as possible. We think a way to do that we've thrown out in the past is just simply making sure the point values for the different categories correspond to their actual relative weight to the overall MIPS composite score. So I think that would be a really simple way to, okay, so that's 5 points, that means it's 5 out of 100 points for my MIPS composite score, rather than sort of like every category has its own scoring and it all translates differently. So that is all from us. Again, thank you, and we will be submitting written comments because I know that was a lot, but appreciate the opportunity that you guys are providing here today.
Great, thank you, Suzanne. Okay, next we will go on to Samantha Sugarman, who is speaking from the American College of Radiology. Right, Samantha, you may go ahead.
Thanks, can you hear me?
Yes, we can.
Okay, great. So thank you again, thank you for having this opportunity for us to speak. And I'll be speaking on behalf of the 34,000 diagnostic, interventional radiologists, radiation oncologists, and medical physicists that are particularly identify imaging care as one of the organization's primary aims and goals. I also want to echo some other comments that we are also part of the registry coalition that Angela had spoken about, and largely support the statements that she's made. And some of the topics have come up already, so I do apologize for some repetition. However, it's still, I think it bears saying, particularly for radiologists, that as non-patient facing clinicians, practices and services have not fit completely into traditional MIPS requirements, particularly the cost and promoting interoperability categories. CMS has provided for alternatives in reporting and scoring to allow successful participation in MIPS and should provide alternatives within MVP structures for these clinicians. In the initial implementation of MVPs, if it is the case that an MVP is only able to include non-specific, non-applicable cost measures to the MVP patient population, like the TPCC or MSPB measures, and or the promoting interoperability measures are not relevant, CMS, we would hope, would provide scoring variances or alternatives such as category reweighting in MIPS. However, the question is then, what benefits would actually be gained by using a quote cost/PI measured deficient MVP for either patients or clinicians using them? And why would that be better than traditional MIPS? In a full swing MVP development, to make an MVP meaningful, CMS would need to consider non-traditional cost or use of information technology measures, appropriateness category requirements, use of advanced technology and HIT such as structured or standardized nomenclatures and diagnostic finding management systems, closed loop follow-up recommendations, tracking and monitoring systems, or radiation dose index monitoring, tracking, and improvement systems can contribute equally to high-value, high-quality care, as do the traditional costs and PI cost measures. And then also, I'd just like to reflect back on something that was said earlier. I think Jill may have brought it up earlier, and we just wanted to say it here too, which is that there shouldn't be a threshold of MVPs available, and that we are concerned to see that a question was included that that CMS shouldn't disenfranchise any MIPS eligible clinicians by not designing or providing a means for them to successfully participate in the QPP. In an even larger way, this is the same issue as the idea of using only one-size-fits-all population-based quality measures. There are many clinicians to whom these will never apply. All transition of MVPs must address this variability and provide equitable alternatives to all. As mentioned by others, also of issue for radiology is the extensive subspecialization found in radiology practices such as thoracic imaging, neuroradiology, breast and women's imaging, as well as MSK. The care team approach, succinctly described by Jill and others, is a focus that is so very applicable to radiology care and so integrative to coordination of care. Non-patient facing does not mean non-patient centered focus. At that holistic design would be better mirror the patient's perspective of their care journey. Thank you.
Great, thank you, Samantha. All right, and just as a reminder to everyone providing feedback, we just remind you to please keep your comments to 5 minutes.
Hi, can you hear me? Hi, can you hear me?
Hi, sorry, Lauren is having some difficulties, but yes, we can hear you. Go ahead, Colleen.
Okay, thank you. Sorry, I got the message saying I was up next to speak. So thank you again for this opportunity. You know, I think it's appropriate that, you know, we speak on behalf of pathology immediately following radiology because we have many similar concerns that I won't fully reiterate regarding, you know, the diagnostic specialties and non-patient facing clinicians. However, a couple of specific things that I think we really want to make sure are considerations, and you know, these are a little bit more open-ended with respect to cost measures. As mentioned, we really encourage CMS to consider broad quantifications of value, not just specifically the cost measures that are developed right now. I think there's a lot of ways to measure value that are not captured by the existing set of cost measures, including the generic cost measures. With respect to the quality measures, CMS has specifically requested feedback on reweighting of the objectives if there are not sufficient cases within any one objective. I think we would certainly support that. We absolutely have concerns about clinicians having sufficient cases for a patient voice objective. Alternatively, I think we could see a way in which additional objectives were created and there were a minimum number of objectives. So for instance, if there were 5 objectives instead of 3, clinicians could be required to report on 4 of them or 3 of them or something like that. I think that's a little bit difficult when there are only 3 objectives, but if there were a greater number of objectives, there could be a minimum number of objectives that had to be reported on. Again, I think we have similar concerns as have already been stated regarding the population health and administrative claims measures, not only the difficulty in attribution of those, but also in the way individual clinicians can have any effect
on those measures. Specifically, we did want to bring to CMS's attention the idea of what would happen with respect to quality measures that are considered topped out. I think many people have mentioned the burden of sort of creating and also of maintaining MVPs. I think this is something that we want to think of sooner rather than later, that an MVP isn't done as soon as people start using it, but we have to constantly be updating it, making sure that it remains relevant like that. And one of the things to consider is if a measure is topped out, does that mean the whole MVP has to go away? Does that mean another measure has to be immediately made available? Or is CMS considering something a little broader, such as the whole MVP would stay until the MVP would be considered topped out, as opposed to kind of pulling pieces of it apart? Just to consider the maintenance phase of MVPs as well as the creation phase. And then finally, we respect that CMS is currently rolling out Meaningful Measures 2.0. We think we always want to be in alignment with whatever CMS considers the current most meaningful areas to them, how they're defining that. But we also want to make sure that we're not kind of going in two different directions here. I think we would like to hear more about how Meaningful Measures 2.0 fits into MVPs, what the synergy is between those two, if only things that fit into Meaningful Measures 2.0 will be considered for MVPs, or whether those are still totally separate programs. So that's basically all I have to say. I thank you again for this opportunity to speak. We hope to see a lot of flexibility with MVP development, and we look forward to working with you.
Great, thank you, Colleen. Sorry all for the technical difficulties earlier, but hopefully this is fixed now. So next we will move on to Molly Peltzman. Molly is speaking from the American Academy of Ophthalmology. And Molly will go ahead and unmute your line.
Oh, I already made my comments, but thank you.
Okay, great. Thank you, Molly. All right, so we will move on to Lori Johnson from University Physicians. And Lori, we will unmute your line. If you'd like to unmute yourself, you may go ahead.
Hello, I would just like to comment on the reporting. I think that you should allow reporting by performance category. I don't think that you should do anything fancy with picking measures from multiple objectives or weighting different objective categories. All of that just adds a lot of complexity to the overall program, and what you do is you end up trying to figure out and make sure that you've ticked all the boxes so you're considered a successful reporter, but then you're also trying to optimize your score and see how you're going to do. I think you need to make it as straightforward as you can, because it's already at a fairly high level of complexity, and especially for those providers who are in small practices, they don't have a lot of support, administrative support, to help them with this. So oftentimes it's a single practice manager or office manager or provider who's trying to sort through all of this and figure it out, and that's a lot for them to do. So the more streamlined, the simpler, the better. And then I was also thinking back about the subgroups and in terms of reporting. So if you implement subgroups earlier, it was my understanding that the subgroup eligibility and their specialty determinations, like non-patient facing and those kind of things, would still be at the overall group 10 level evaluated. But I don't think you're really going to be able to do that if people are implementing subgroups, because then you're going to have subgroups and they're going to try to find an applicable MVP, but the clinicians that make up that subgroup, it might not be appropriate for them to report PI. And mostly I'm talking about those non-patient facing providers. So in our multi-specialty group, I think about our radiology providers, our pathology providers. Our overall group 10 would need to report promoting interoperability, but that subgroup wouldn't. So I guess how it would work is that our overall group reporting would apply to that subgroup. But what if you don't do overall group reporting? What if you're a multi-specialty group and you break your whole TIN into all of the specialty subgroups because you're trying to get measures that are meaningful to everyone? I don't, even with subgroup creation, I don't think you're going to be able to get a measure set that's applicable to every NPI that's within your TIN, because even within a specialty, you have subspecialists. Within an orthopedic group, you have hip and knee, you have ortho trauma, you have ortho spine. And so you're never going to find all the measure sets that are applicable to that entire group. I also think in terms of the improvement activities category for MVPs, you should just let them pick from the whole list. There's already a requirement that more than 50% of the eligible clinicians within a group have to participate in the improvement activity. So you're going to, by that standard alone, ensure that they're picking something that is most applicable to the group. So you should give them the most choice that you can. And I think that does it for my comments on this section. So thank you very much for the opportunity.
Great, thank you, Lori. All right, next we'll move back to Asia Shukla. Asia is from University Physicians. And Asia, you may go ahead. Asia Shukla, if you'd like to provide your feedback on this section, you may go ahead. Okay, we will move back to Kevin Wong. Kevin, again, is speaking from the Hospital for Special Surgery. And Kevin, if you could unmute on your end, you could go ahead.
Hi, I actually think all of our comments have been covered already, so I'm going to yield my time to others.
Great, all right, thank you, Kevin. All right, next we do have Karen Davidson. Karen is speaking from the American Society of Plastic Surgeons. So Karen, we have unmuted your line and you can go ahead.
Hi, thank you. Appreciate the opportunity to provide this feedback. ASPS is concerned that CMS appears again to be taking a one-size-fits-all approach, which has also been our frustration with MIPS to date. MIPS, whether reported by traditional or via MVPs, requires all eligible clinicians, not just primary care physicians. And although I'm speaking for plastic surgeons, I do believe my comments are likely relevant to other smaller specialties and echo those of some of the non-patient facing colleagues who have already previously spoken. So to start, having PI as a foundation for MVP is just problematic off the bat for many specialties. You have specialties that are exempt outright, and then there's specialties like us that have many small practices who would take the exemption. Even those who in our specialty who do opt to report, they get excluded from almost all of the measures. They don't have a disease process to report on. They don't have immunizations. We don't have surveillance. So really, we end up being scored only on the provide patients electronic access to their health information, and that's the entire. To base something on that measure seems difficult. Then you go to population health, and the hospital readmission measure doesn't apply to us. The majority of MIPS eligible clinicians for plastic surgery, who again would mostly work in smaller solo practice, perform skin cancer reconstructions. These are procedures done almost exclusively in outpatient office or ambulatory care settings. We have no primary admission, let alone readmission. And then cost, as many other people have said, there's no relevant cost measure for plastic surgery. There's a melanoma cost measure coming out soon, but that's still only a very teeny tiny fraction of the skin cancer treated by plastic surgeons. We're typically excluded from the MSPB and TPCCs due to attribution. So episode-based cost measures, as other people have spoken to well, don't lend themselves well to specialty that functions as part of a care team. And then with all of these categories being reweighted, we now have an MVP that's based on quality with a little bit, small percentage to IA, which doesn't really differ from traditional MIPS at all. So it's hard to see the purpose of putting all this effort in when we're not really getting anything out of it. So we really urge CMS to consider different foundational principles for specialists, or to consider different models of measuring cost. There's appropriate use and healthcare utilization measures that can speak to cost. And then to answer one of the other questions, we would not recommend weighting quality measures differently. It just seems too complicated, as I believe ACP had talked about. So that's, I think, all I have right now. Thank you.
Great, thank you, Karen. All right, and we are going to pass it back to Corinne Rubin from the American Medical Association. So Corinne, we'll try this again. Let me know. Well, actually, you're unmuted, so go ahead. All right, Corinne, if you could try one more time, we'll unmute your line and you can go ahead.
Can you hear me?
Can you hear me? Can you hear me? Okay. Yes, we can. There is an echo if you're able to mute your computer as well.
Yeah.
Okay, perfect. Corinne, are you still there? Okay, not sure what happened there, but we will follow up with her. In the meantime, Sophia, we will pass it back to you to go over a few questions. Thank you.
Good. Can you hear me? Can you hear me now?
Yes, we can.
Okay, great. Sorry, I just wanted to make sure. And so I know we, through the feedback we received, thank you all for all your robust feedback, very helpful, and we've been jotting down a lot of notes. I wanted to address some of the QCDR related feedback only because, well, I've worked closely with the QCDRs thus far, and I figured since these were items we tried to address in the rule, we tried to provide a bit more clarification today for you all, and then I'll turn it over to Molly to continue onwards with any additional feedback she might have. So with regards to the QCDRs supporting MVPs and also the qualified registry supporting MVPs, in the 2021 rule, we did finalize that they would be able to do so as soon as MVPs are, implemented within 2022 and future years. We did not, and specifically with that, with QCDR measures, we mentioned that, we did not make any changes to our existing QCDR measure policies. In a sense, QCDR measures are only reportable through QCDRs. They are not reportable through qualified registries. So in a sense, when you think of our MVPs and our thought of giving clinicians choice within the MVP of which measures they can select, if they are working with a qualified registry, they cannot report those if there are two QCDR measures, for example, within the MVP and the others are, MIPS quality measures, they would have to choose from those MIPS quality measures. They could not report on those QCDR measures. However, the flip side of that is if they use the QCDR, then they have the option to report any of those measures that make up the quality component. And those existing policies around permission, measure permission, and licensure, those will continue as is. So, the expectation is that if you are reporting on an MVP that includes QCDR measures from another QCDR, the expectation is as a part of that self-nomination process, you would have received the permission associated or required by those QCDRs who own those measures if you are not the owner yourself prior to electing to support that MVP. If we are not tracking that you have permission, then you would not be able to report that measure on behalf of the clinicians. So again, the inclusion of QCDR measures is good and it's welcomed, but you still need to follow the appropriate steps and policies that have existed. And because we are allowing for choice within the MVP, the assumption is if you do not have permission to report that QCDR measure or not a QCDR, you would not report those measures. You would focus in on the other ones. So that should be taken into consideration as a part of the planning for all QCDRs, qualified registries, other third-party intermediaries with regards to, determining when and which MVPs they'd like to support, depending on what specialties they support. With regards to, I believe the American College of Physicians had a question related to whether a QCDR measure could be included within the candidate MVP submission, and if that the timing of that candidate submission is submitted to CMS simultaneously or a little before the actual self-nomination process happens, and so technically that measure isn't fully fully approved yet, but it's making its way through that process in the upcoming months or weeks. That is fine. We would, of course, not make any approvals of that measure or anything like that. That would all be contingent on its approval through the self-nomination process. The expectation would be that, that the approval of the QCDR measure would happen in the months prior to us working on the rule and putting pen to paper to actually finalize what we want to move forward. So that would just be something we would track to. The expectation would be that that would be something that would be clarified, because if we weren't able to approve the measure for some reason through self-nom, that appropriate adjustments would have to be made to that MVP if there are alternative measures that should be considered. And just a larger caveat, there are different timelines between self-nomination and the rule timeline. So just to be mindful of those differences, with self-nomination occurring between July 1st and September 1 of a given year, and then we utilize the month after that to kind of address any issues or approval, or go through our approval process with the QCDR applications and the measures themselves. And then with rulemaking, again, we have finalized in the 2020 rule all MVPs will be subjected to notice and comment rulemaking. So if you have a QCDR measure, the same would apply there. If you include an MVP that has QCDR measures in it, all components of that MVP, including the QCDR measure, would have to go through notice and comment rulemaking. So I just want to flag that as well. There is no approval of MVPs through a sub-regulatory means, which means we would not approve MVPs through self-nomination. And I think that's all I want to clarify with the QCDR related items. Certainly after this meeting, if there are additional questions, we are certainly open to receiving them and helping to clarify any additional information. But Molly, I'll turn it over to you to see if there's anything else we'd like to address.
Okay, thank you again, Sophia, and thank you again to everyone who has joined today. We are quickly coming to a close. We only have about 15 minutes left. But before we get into our closing remarks, I did just want to do a quick one last call and one last pause to see if there's any additional feedback that folks want to provide to us that you weren't able to provide verbally through our sessions. And this could cover anything that we covered today within our sessions 1, 2, or 3. So for folks who do want to be unmuted, if you can proceed with raising your hand so we can unmute you. We probably only have time for a couple of folks' feedback, but that's the last thing I'd like to do before we adjourn. So Lauren or Lindsay, just let us know if we have anyone else who'd like to give us feedback before we adjourn today.
Great, thanks, Molly. Okay, again, while we wait for a bit more hands to be raised, feel free to always submit some written feedback to the inbox that we will share through the chat box momentarily. In the meantime, we have Suzanne Joy from ACP who would like to make some remarks. So Suzanne, you may go ahead.
Thank you. I actually have a couple of more technical questions. If you all are able to answer, that would be awesome. If not, totally understand if you need to take it back and get back to us. One thing that had been kind of spinning around the subspecialty societies and some discussions with other organizations is how you guys are approaching the foundational layer in terms of scoring. My read was that that's more just like kind of consistent from MIPS carrying over to MVPs, but the 4 categories are still going to be kind of scored more or less the same. So it's not really impacting scoring as much, but I wasn't 100% sure if that read was correct. And then my second question was, I know in our MVP, it seemed like we were moving more in the direction of total per capita cost as the cost measure. But then in these materials, it seems like we're adding back in Medicare spending per beneficiary. So I was just curious if, that has changed, I guess, formally, and you all plan to include those both cost measures in all MVPs kind of universally, or if it's going to kind of vary per MVP, if that makes sense. So thank you.
Sure, thanks, Suzanne. I can try to answer some of those questions, and then we'll probably have time just for one other commenter before we adjourn. So I'll take your last question first. So do we have a sense that moving forward for the cost performance category, we want to include the MSPB and total per capita cost measure uniformly? To that, we don't feel that we have to include those measures in all MVPs. As folks have commented throughout today, and as we've discussed in prior MIPS and MVP sessions, we do recognize that there is not a large set of cost measures that are currently available. We do understand that, again, the vast majority of clinicians do not have a cost measure that applies to them in the fullest manner. With that being said, though, we do recognize and anticipate that as we move forward with MVPs, there will need to be assessment within each of the performance categories. So that's probably why for organizations such as yourself, Suzanne, ACP, where you guys have been working with us really since the onset of MVPs, you're seeing more of that coming back into play. Because we do believe that for us moving forward with MVPs, we would ideally like to have a measure or activity within each performance category. Again, this is our thinking. We are still within that special time where we are not yet in rulemaking. So happy to hear feedback from others, there probably won't be time here today. So any written feedback that you guys have in regards to that clarification I just provided. And I think your first question, it was related to scoring and how we're thinking of score and promoting interoperability. So as Sophia talked through within the slides earlier today, going back to slides 34, 35, et cetera, we did indicate within there that, our vision includes that there would be assessment on MVPs across all 4 performance categories. As we've said, numerous times here today, as well as in past sessions, we do want the MIPS program to look differently, but we must still, of course, maintain our statutory compliance, and that, of course, calls for 4 separate performance categories. So our thinking for promoting interoperability so far has been that with it falling within the foundational layer, it would still apply to MIPS-eligible clinicians similarly to how it does today. We can't, of course, confirm that there wouldn't be any additional changes that would be made, but we think it's a relatively safe assumption that if you currently are a clinician that has the ability to have that category reweighted, such as if you're a non-patient facing specialty, that would continue. Again, it could change through rulemaking. And with that, Lauren, why don't we see if there's one last commenter or for any feedback that they'd like to share with us today?
Sure. Yep. We do have one more commenter. So Samantha Sugarman, we will go ahead and unmute your line. Give us just a moment to go ahead and do that. Okay, apologies. We actually do not have any more hands raised for feedback at the moment. So we can give it one more moment before we conclude.
Okay, and Lauren, while you're just checking to see if there's anyone else, why don't I just briefly go over some of the themes that we heard from this afternoon. Again, this is not in any way conclusive of everything that you all have shared with us today. There was a lot that was provided, and I know the vast majority, if not all of you, will also be providing to us written feedback next week, but let me just touch on some of the themes that we heard. So we heard that there was overall that folks are not in favor of retiring our traditional MIPS program, especially in the near future. We also heard themes that we need to have more measures developed, particularly cost measures. That's a nice segue from what we were just talking about. One of the additional themes that we heard is the role of the patient. I think I heard pretty uniform agreement that that is very important, but that the feedback that I was hearing is that to us is that we should be thinking about patients in a broader sense. Not only from measure development to different ways that clinicians work with patients on their goals. So broadening that picture to not just being, for example, patient-reported outcome measures or patient experience measures. One of the other themes that we heard was overarching a high amount of interest in MVPs, and then also, and then two other themes that we heard were concerns on the reasonableness of the timelines, and then the last theme that at least I was able to capture was that we're not in favor of objectives that complicates reporting. So I think that's another area that we're going to take a closer look at. And Lauren, do we have anyone else who wanted to make any last comments, or is that it?
Hi, Molly. It looks like we do have one comment remaining from Samantha Sugarman. So Samantha, we've gone ahead and unmuted your line.
Thank you. I tried speaking earlier, but I don't know what happened. So my comment is more along the lines of something that wasn't included in the packet, but was included in the proposed rule, and then I couldn't find it in the final rule. And it had to do with transparency and MVP in the MVP rulemaking process. So I recall in the proposed rule that CMS had sought comments on stakeholder input along the lines of an annual call for MVPs similar to that of the call for measures, and then to have it go through some type of multi-stakeholder review process. And I'm just using the example of it being similar to that of the MAP, right? And so my comment is that I don't recall having seen anything about that in the final rule. So with the idea and knowing that 2022 will be the first year that participants may be able to use MVPs, I am interested in knowing, and I know we're interested in knowing how that will be addressed for future MVP approval. And obviously, like I know in several areas I read, CMS ultimately has the responsibility to approve or not approve MVPs, but it is important to us that from my perspective from radiology, that radiologists have an opportunity to help make the decision with CMS under their decision-making auspices, if you will.
Yeah, hi, this is Sophia. I can address that question related to the call for, or something similar to the call for measures process, but with the MVPs. We did address it in the final rule. It might have sounded a bit different in the sense where we've said we would establish a kind of like an ongoing process, essentially, where it would be kicked off by this webinar we had in December, which was the MVP development webinar. We would publish a MVP candidate template, which we have already in the QPP resource library. And essentially, we would accept MVPs on an ongoing basis. In a sense, if there's no set deadline, what we did mention in the December webinar was that if you would like your MVP to be considered for 2022, we would ideally like to receive it by end of February, and that's really just to give us a little bit of time to process and also, have that outreach to the given stakeholder who submits the candidate and stays within the confines of our rulemaking timeline. We did see comment through the proposed rule related to whether we should have some type of committee set up, something similar to what the measures go through, but that is not something we finalized as a part of the process. So for the time being, we've established a process where we would just receive your submissions, candidate submissions, and then review those, really have iterative dialogues with you, the stakeholder that develops the MVP, creates the MVP, and kind of collaborate on, revising if needed, or the back and forth to make sure the MVP is meeting our criteria. And that from that point onwards, as you've mentioned, it's ultimately CMS's decision as to when the MVP will be implemented. And really we would rely on the rule to kind of inform the public of which MVPs we intend to propose and implement in the future year.
Great, thank you, Sophia. All right, that
Thank you.
concludes, that's all the time that we have for feedback on session 3 and therefore on the town hall. So what we'll do is pass it back to Katie Moore to go ahead and conclude today. Unfortunately, it looks like Katie is not connected to audio, so Molly or Sophia, we will pass it back to you.
Okay, thanks, Lauren. This is Molly again. So let me just wrap things up. So thank you to everyone for your feedback here today. Again, we really, really appreciate it. As you all have seen, not only from myself and Sophia, but the movement of going to MVPs and moving these forward, it is very important to us here at CMS. Again, you saw that not only from Sophia and I, but also from our leadership, Dr. Michelle Schreiber, as well as Dr. Lee Fleischer. So we are committed to making MVPs work, and we really value all of the feedback that we've heard from you all today. Again, I do just want to reiterate that we very much would like to receive feedback in writing from you all as well. And you have up through next week to send us that feedback. And Lauren just on this slide here, so it's the email address cmsmvpfeedback@ketchum.com. That's where we'd like to receive the additional feedback. Again, we are at this unique time frame where we are not yet in rulemaking, so we don't have our cone of silence, where we actually can have a bit of a dialogue with you all as we look to solve a number of these policy objectives and continue to move the quality payment program towards value. So thank you all again for your time today. We very much appreciate it, and looking forward to your feedback that we receive in writing. Thank you again.